Hello, 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 my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, May 22nd. It's a beautiful day here in Northern California, and it is time for another live support group meeting. It's getting harder for me to start these earlier because hi, Sylviane. My mom and my dad both need a lot of care now in the morning, so I have been so busy this morning, cleaning things, cleaning the kitchen, making breakfast for both of them, helping them bathe. You name it, I'm doing it. Putting hearing aids in. So I apologize that I'm not able to start it right at 12:30 right now. I just can't. I just don't. I can't do it. I have to get my mom up first, and she tends to get up pretty late. So anyway, but it's done. She's dressed. Yes, her brunch is on the table. So life is good. So how are you today? How is life treating you today? I hope that you're having a good day. It's been a challenging week. Hello, Erica from the United Kingdom. How are you today? It's nighttime for you. You're 8 hours ahead of us, so it's night. Erica, I watch a guy on TikTok who broadcasts live as we're going to bed. He walks through London broadcasting live. And so I was watching him last night a little bit. Hello, Amanda is in pain. Dang it. Amanda, what kind of pain are you having, hon? Are you having bladder wall pain, pelvic floor pain? What do you think's triggering your pain today? Hi, Deborah. Nice to see you. Hello, Rhonda. Rhonda said she was wondering was wondering where you were. Yeah, I'm in Northern California. We're in Sonoma County, California, which is about 80 miles north of San Francisco. And it's a beautiful series of valleys that are kind of filled with vineyards, but they also burn. So we have been in our first kind of major fire thing for a couple of days now. So yeah, 9 p.m. there. Looked cold. Looked like you guys were having some storms over there. So Anne says, so how do you get a diagnosis of IC without pain? Well, I mean, it's a diagnosis of IC is based upon your symptoms. Do you have frequency, urgency, pressure? Does it get worse as your bladder fills with urine? Are they unable to find anything else responsible for it? Have they done a proper urine culture? Have they done a pelvic floor assessment? Have they looked for other things that can cause it, et cetera, et cetera? Now, you guys, last week was my first day talking about the new IC guidelines, and I promised you that I would have a fact sheet that simplified it all, and I finished it yesterday. So this will be available on our website, hopefully tonight. I didn't have the time. I was going to get it on this morning, but my mom was taking a lot of my time this morning. So we've had a week now to sit and ponder about these brand new guidelines that we have for interstitial cystitis. Now, understand that the entire reason why we have guidelines is because we want patients to be treated correctly. And consistently. We don't want patients in Alabama to be treated than patients from Michigan to be treated than patients from Arizona and California. We need consistency here because our challenge here is that, especially because we spent many, many years with medical schools teaching that IC was all in your head. And I've told that story, let me just tell it to you again. So IC, or this irritation of the bladder, was first documented in England in the 1800s. Beautiful, beautiful discussion of it. I actually read the original article. It's beautiful. They use different language, but it could work today. A patient with frequency, urgency, pressure, and/or pain in the absence of an obvious cause. And then in the early 1900s, when they developed the cystoscope and they could look in the bladder, they started looking in our bladders and they found lesions. In fact, Guy Hunner, the guy who was responsible for documenting a Hunner's lesion, which is why it's named after him, was the one who absolutely said, yes, look at the bladder. By golly, there is a wound in it, right? And then as the 20s and 30s went through, and of course we were dealing with World War I and then World War II. During World War II, we had some research that showed that it affected men and children in the 40s, maybe late 40s, or maybe even early 50s. And then about 1958, or so, give or take a couple months, a couple of arrogant pricks of doctors published a case study in which they claimed that a young woman with these symptoms had pain, that she had anger manifested in the pelvis, and that it was clearly a mental and emotional disease for her. And so from that moment, literally till about 1990, we're talking a good 40 years, most medical schools talked about interstitial cystitis as being mental and emotional. And in fact, it was Dr. Dan Brookoff who, when he came to California and spoke at one of our early IC conferences, he explained when he was in medical school in the 70s, literally he did one, because he was an internal medicine doctor, he did 1 day of internal medicine lectures with a very prominent urologist. Well, it was he was a resident, and he went to a 1 day lecture of urology topics. Sorry about that, I got that backwards. Very prominent urologist, and literally, as the guy is at the very end of the day, and he's literally packing things up. He goes, "Oh, there's another condition we need to tell you about. These patients are going to drive you crazy. They're going to call you all the time. They're just going to make you crazy. It's called interstitial cystitis, and it's all in their head." And so one of the residents from the audience basically said, "Well, how do you treat it?" And he said, "Well, we pretty much just take their bladder out." Something very kind of passive aggressive like that. And then another resident said, "But if it was all in their head, why would you take their bladder out? Why would you take their bladder out?" At which point in time, the guy packed up and walked out of the room because he didn't have a good answer for that. So we do have to understand that many of the doctors that are now at the point of retiring really were never properly trained in it. And it was only like 5 or 6 years ago that medical board exams actually had a question about IC. Right. And so we've come a long way. We've come a long way. Now we know it certainly is not mental and emotional. Now we know, through well more than $100 million invested in research by the US government, that this is a real condition that affects patients in many, many different ways. And they certainly deserve care. They should not be told that it is all in their head, and they should not be sent to mental hospitals, et cetera, which is often what they did in the 60s. So we've come a long way, right? So the purpose of these guidelines is, number one, to validate that this is absolutely a real condition. And number two, to give both you and your doctor a very clear understanding of what we know about IC to this point and what our correct therapies are. And so let's just go through a couple of the big points here. And again, I will have our fact sheet on these guidelines, just 4 pages long, available on our website for download soon. And then if you're a member, it will be in our magazine with a much, much longer discussion of it, right? Okay. So the first thing that is very, very important that you understand now is that we no longer think of IC as a bladder disease, and the guidelines confirm it. We look at interstitial cystitis as a chronic pain syndrome. Why? Because for many of us, structures outside of the bladder are often involved. Right? There's diversity in our patient population. For some of you, IC begins in childhood. For others, after menopause. For some of you, IC begins after you fall and break your tailbone. While for others, it begins after chemotherapy. Right? We're not all the same. Another thing the guidelines say is a one treatment fits all approach does not work. Bladder therapies do not work for many of us. In fact, maybe even most of us. Why? Because many of us, myself included, have a perfectly normal bladder. And there's no doubt we have frequency, urgency, pressure, pain, but the reality is that the bladder is sometimes a victim of another process happening in the pelvis or with our central nervous system. So concept number one, it's IC is no longer considered a bladder disease. It is considered a chronic pain syndrome. Got it? Number two, now you remember what I have been hammering away at you guys for the last 5 years are subtypes. Subtypes. There's diversity in this patient population. And we don't want you to be doing bladder therapies if you have a healthy bladder, just like we don't want you to be doing pelvic floor tension if you've got normal pelvic floor muscles. We want to find the right treatment for you. Right? In the old days, when you came in, they said, hate to break it to you, you got interstitial cystitis, it's incurable bladder disease. Here's some Elmeron, here's a diet, I'll see you in 6 months. Okay, we don't do that anymore. We don't do that anymore. Now, a good diagnostic workup is going to try to focus on what your unique anatomy is. So in the Chris Payne system, he focuses on 5 core subtypes: Hunners lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, right? Now, AUA kind of combined a few, but they completely support Chris Payne's finding. You have to understand with AUA, with the American Urology Association, they practice evidence-based medicine. Man, they want research study after research study after research study confirming data, right, before they talk about it. And so they're not quite willing to embrace, for example, pudendal neuralgia, but their subtypes are almost identical to Chris Payne's subtype. So their first subtype is bladder-centric. These patients have clear bladder wall dysfunction as demonstrated by the presence of Hunners lesions, a small bladder capacity, and or pain that improves with a local anesthetic. If they put lidocaine in your bladder and your pain goes away or your symptoms improve, then we know the nerves in your bladder are driving your symptoms. Concept number 1, bladder-centric. This group could also include patients with estrogen atrophy or chemical irritation of the bladder wall. Patients with Hunners lesions should be immediately directed to Hunners lesion therapy. They are no longer saying you've got to wait and try oral medications first. If they suspect you have Hunners lesions, especially over the age of 50, they're going to probably want to do or at least a cystoscopy, maybe cystoscopy with hydrodistension to look for lesions, because if we find the lesions, we can treat the lesions. And guess what? The research shows that the pain goes away in the vast majority of patients. Like 87 to 90% of patients who get their lesions treated have a dramatic improvement in their symptoms, or the pain goes away. So now they want to actively look for lesions and they want to treat them correctly. You know, and I was working with a patient on Friday who literally had untreated lesions for a decade. And you know, so 10 years ago, the doctor found lesions in her bladder, and I said, well, did he treat them? And she said, no. And I said, you know, at this point in time, that's almost malpractice, because we know when it receives correct treatment, you will do dramatically better. So understand that. So concept number 1, bladder-centric. Number 2, patients who, pelvic floor, patients who have a tight, sensitive pelvic floor muscles, their immediate goal is to restore normal muscle tone, resolve painful trigger points, ease tight constrictive tissue. All patients with tight pelvic floor muscles should be immediately referred to pelvic floor physical therapy. So again, we're not waiting. The long-term consequence of pelvic floor tension is a bit unknown, but it makes sense, because if you got tight muscles, you're dealing with ischemia, you don't have good blood supply. How is the bladder going to be healthy? How's your vulva going to be healthy? How's your testicles going to be healthy, et cetera, if it doesn't have good blood supply? So if they find that you have tight pelvic floor muscles, they want an immediately referral to a pelvic floor physical therapist, okay? And then the third subtype in the AUA guidelines are patients with chronic overlapping pain conditions, Chris Payne's IC subtype 5. These patients have one or more pain conditions beyond the bladder: IBS, fibromyalgia, vulvodynia, TMJ, migraines, etc., which tells us that their central nervous system is the underlying problem. They have signs of central sensitization, anxiety, depression, and or history of trauma and or abuse. And of course, what do we know now? We knew that we learned this a couple of years ago, that these patients, their brains are stuck in fight or flight. It's called the central nervous system maladaptation. It's not mental illness. Nobody's saying there's any mental illness involved at all. It is a bit of an injured central nervous system that is stuck, thinking that your life is at stake 24 hours a day, and that intensifies pain, and that causes tight muscles. And so we're going to be treating these patients very, 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 very differently, right? Very, very differently. We're going to focus less on bladder therapies and more on other things. Hey, you guys, thank you for the stars, by the way. Erica, 200 stars and 99 stars. So appreciated. Thank you very, very much. All right. Now, how did the diagnosis, did the guidelines change how we're supposed to diagnose IC? And the answer is not really. A diagnosis of IC requires careful history, physical exam, lab tests. You must have had symptoms for 6 weeks to be considered for a diagnosis of interstitial cystitis. And if you have pain and discomfort as your bladder fills with urine, or you have food sensitivity that pushes you further down the interstitial cystitis pathway, okay? They are also absolutely emphasizing that your doctor should be actively trying to exclude any other conditions which can mimic these symptoms, such as urinary tract infection, masses, hernias, tight pelvic floor muscles. And they're also really, in a very, very correct way, reminding us that if there's any finding of visible blood in your urine, or even microscopic blood in your urine, just out of due diligence, they should screen you for bladder cancer. If you have a history of tobacco exposure, if you were a tobacco smoker, or you lived in the home of somebody who is a tobacco smoker, that is the #1 cause of bladder cancer. And so you should, and the odds are they've already done it. The odds are they've already screened for it anyway. But, especially, again, I was working with a patient and I was like, had anybody actually looked in her bladder? No. That's absolutely when we want to take a look in the bladder, see what's bleeding, and certainly screen for bladder cancer. Alrighty. Patients who are not peeing a lot, they don't have frequency, they're sleeping through the night, or patients who have a large bladder capacity, they can hold a lot of urine. Their AUA is telling doctors to look for an alternative diagnosis. They really don't believe that these patients could fit in the IC group, that there's probably something else going on. They want you to do a 1-page voiding diary at the start of your symptoms so that you can use that 3 months later, 6 months later, a year later to see if you're improving. If you have a complex case and the doctor is actually kind of baffled, not sure what's causing it, they might want to do, and they encourage the use of a cystoscopy to just take a quick look in the bladder and let's see if there's bladder cancer, bladder stones, urethral diverticula, or any foreign bodies in your bladder. The best example of that was a patient who was with us last week who had vaginal mesh surgery, and the mesh, actually I worked with 2 patients, the mesh had moved and punctured her bladder and was now in her bladder. So you want to look for foreign objects, okay? Understand too now, a lot of you say, when you had your hydrodistension, they told you, well, you didn't have Hunners lesions. You had little pinpoint red spots that we call petechial hemorrhages or glomerations. And remember, we all thought that was IC years ago. We now know it's not, that happens to healthy people too when you stretch their bladder. So the finding of glomerations is now thrown out. Glomerations are no longer considered specific to IC as they are seen in other conditions. Let's see. Okay. If Hunners lesions are suspected, they want you, especially if you're of the age of 50, they want you to have an office cysto. If they choose to do a hydrodistension, it should be low pressure, short duration, under 10 minutes long, to reduce the risk of bladder rupture. So it's interesting. Let's see. I want to see if I can remember this correctly. Oh, you know what? I'll come back to that. It'll be further on anyway. So again, a diagnosis of interstitial cystitis is a diagnosis of exclusion. We want to rule stuff out. That makes sense now that we know that this is a chronic pain syndrome. And we don't want you to be on therapies. One of the core concepts of the guidelines is if you're not getting better, if you're worsening rather than improving, it's time to take a step back and revisit the diagnosis. They don't want you to do treatments that are ineffective. They don't. They want you to stop what you're doing, take a step back, revisit the diagnosis. What did we miss? Did we miss anything? Like a fibroid tumor pushing on your bladder, or endometriosis on your bladder, or an old bicycle injury. Again, I was working with a patient last week and it was a gentleman, and we're always doing the traumatic injury dance because so many men have a history of pelvic trauma. And it's like, do you remember any major trauma? He's like, no. And it's like, did you ride a bike? He goes, yeah. And I go, so do you remember anything happening on your bike? And he goes, oh, yeah. He'd had a really bad bike accident. And I think he had broken his tailbone and jammed his testicles and his scrotum on the actual bar of the bicycle. That's something that we're always looking for. Again, if you have any history of trauma to your pelvis at all, you have to make sure you tell that to your doctor. Treatment approach. No single treatment works over time. Treatment should be tailored to the specific symptoms of you. We don't want you to fit the treatment. We want the treatment to fit you. AUA has abandoned the 6-step treatment protocol. That's probably the most controversial thing that they did. The old guidelines, they wanted you to start at step 1, do everything in step 1 before you go to step 2, do everything in step 2 before you go to step 3. And that was a really good way for you, the patient, to understand the risk of treatment. It's just a really simple learning method. And they've decided not to do that this time. They want to give the doctor a little bit more flexibility. They didn't want the doctor to be forced to do oral therapies before treating Hunners lesions, for example. So I think that that's the fundamental reason why they walked away from requiring this 6-step treatment protocol. Pain care. Here's another really big part of the guidelines there. And you know, it's funny because somebody gave me an article written by the guy who wrote the guidelines that was kind of the opposite of what he wrote in the guidelines about pain care. AUA is very aggressive about pain management. They do not want you to suffer. And that's one thing that's been consistent at first in 2011 when they wrote the guidelines, in 2014, and again in 2022. Pain must be an integral part of treatment, and pain levels should be assessed at every single appointment. They want you to do more than just one pain therapy. We want to try to address the underlying cause of what's causing the pain, whether it be tight muscles or Hunners lesions, etc. They encourage the use of medications, manual therapy, and even really good stress management, which we shouldn't be offended by. That's absolutely correct. And complex patients may be referred to a pain management professional. That's perfectly fine. If you are using pain medications, the goal is to provide significant pain relief with minimal side effects, including the use of urinary analgesics like azo, NSAIDs, narcotics, and a variety of non-narcotic medications used for chronic pain. Starting doses should always be the smallest. AUA actually recommends that you have a plan for breakthrough pain. And they encourage doctors to be flexible and to consider the use of stronger pain medicine if you have breakthrough pain. And most importantly, they say that pain management should not be the only way you're treating IC. It does not constitute sufficient treatment for IC BPS. It is simply one element of treatment. And that's important. That's important for, now listen, I have been there. I know what it's like to be up all night, bawling your eyes out, begging to God to help you. I understand that the pain is devastating, absolutely devastating. And your number one goal is to try to get yourself out of pain. I understand that. Believe me, I've been there. I was there for years. And so it's perfectly fine to engage in pain management strategies, including pain medication if necessary. But you can't live there. You always have to be thinking about what is the underlying cause of the pain so that you can treat the underlying cause of the pain so that you don't need pain medicine, like untreated Hunners lesions. And so some of you, I will say, have done that, where literally you're just absolutely focused. You need your OxyContin at this specific dose. Nothing else will work, and you're not doing any other therapies. And when you talk to me, I really challenge you on that. It's like, no. I understand. I understand that you need the pain meds. It's fine. But what are we doing to fix the underlying problem? And it shocks them when I say that because they forget it. I mean, honestly, they just kind of forget. They forget it. That you get so consumed by the pain, you forget that there's another way that you can tackle the pain, which is focusing on underlying cause. So anyway, Here we go. For self-help, again, they want everybody to start with good basic self-help at home. You have a lot of control over your symptoms. Yeah, we have far more control than we realize. So what do they consider really good self-help techniques? Number one, making sure you're drinking enough water. Because if you're, a lot of you stop drinking water because you associate that with peeing all night, or you stop drinking water at dinner. Before you know it, your urine is orange. I mean, it's brown. You're so dehydrated, not understanding that that super concentrated urine is actually going to irritate your bladder even more. So we need to get your water intake back up. If your urine is a pale, clear yellow, you're good. If your urine is a dark yellow or brown, you're dehydrated. You've got to get more fluid in there to get good urine dilution. AUA wants you to use heat or cold packs. They want you to follow the IC diet if you're somebody who's diet sensitive. They want you to use an elimination diet to help identify foods which are your triggers. They want you to use over-the-counter supplements like Preleaf. Calcium glycerophosphate is something that you can use to reduce the acid level of foods you're going to eat. And I mean, it's really quite remarkable that they've gone down this pathway, and they have literally for 11 years. They support you being able to use products at home that might help you. And thankfully today we have a lot of over-the-counter supplements that have the potential of helping, like Bladder Builder, Bladder Rest, Peora, Allopath, Cystoprotect, Cystomen. There are some solid products out there now. They want you to do pelvic floor relaxation. When you start feeling your muscles get tight, you got to do something about it. You can't be passive aggressive like I am. In fact, I did it again last week. I could feel them slowly getting tighter, and then like on Friday night, bam, woo, they were locked. My pelvic floor was I was getting that pulling sensation. And I woke up early yesterday morning and I immediately used my wand and it made it go away completely. AUA wants you to address uncontrolled stress and anxiety because this will intensify your pain. You should not be offended if somebody says, hey, you're kind of stressed out. Of course you're stressed out. You're in pain. But we're all stressed out right now with COVID and all the other stuff going on. We have to understand the ramifications of stress. The ramifications of stress is that it intensifies pain. It makes you pee more, and it will, your brain is stuck in fight or flight. We've got to try to get your brain out of fight or flight to calm everything down, including those pain messages, and to relax your muscles. Let's see. There you go. They talk about 5 oral medications. Now, this was very interesting discussion because they go right into the deep research. They want you to understand what the research really says about various treatments. So they talk first about amitriptyline, also known as Elavil, which is a low-dose antidepressant. They say amitriptyline may help reduce pain or depression associated with chronic pain. Research studies show that it may benefit 50 to 64% of patients who try it, with results seen in a month. It appears to be the most effective at higher doses, though the risk of adverse events is high. It's high. It's a hard medication to take, and many of us, myself included, simply cannot take it. The side effects of amitriptyline include dry mouth, urinary retention, constipation, sedation, drowsiness, nausea, weight gain, orthostatic hypertension, and cardiac conduction abnormalities, which is what happened to me when I took it. I took it for 3 months. And it activated, what it does is it changes the conductivity of your heart, of your heart muscle. And in my case, it activated a third node in my heart. So normally you have the SA node and the AV node, which is your heartbeat, like beep, 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 beep. Well, when I took amitriptyline, it gave me a third node. So my heartbeat was beep, 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 beep. Or sometimes it was beep, beep, because 2 of them burst at the same time. Very uncomfortable. Took years to get over that. Still happens every now and then, but it's way, way better. The starting dose is 10 milligrams at bedtime, increasing weekly to 25, 50, and maybe 75, provided you can tolerate the dose. Second thing they talk about is hydroxyzine. Hydroxyzine is an antihistamine, which is particularly effective for IC patients with a history of allergies or asthma. 92% of patients with a history of allergies showed a significant improvement in their symptoms, and the typical dose is 25 milligrams. And you may see benefit just in a couple of days. That sounds good. And see, I was able to take hydroxyzine for years. I had no problems with it at all. The challenging thing with hydroxyzine is that it's a little bit harder to wake up. It's like you have to break through an extra layer of sleep to wake up. But once you're up, you're fine. But the biggest side effect of hydroxyzine is hydroxyzine dreams. You have really, really vivid dreams. So if it's a sex dream, like as we all have had, it is like the best sex of your life with every movie star you've ever imagined type of dream, which is what I had that dream, believe it or not. But if it's a nightmare, it becomes a night terror. And that's why I eventually started it, is I started having night terrors. Cimetidine is a medication that reduces stomach acid, and it was found to be helpful in 44 to 57% of patients, and no adverse events were reported. So of all of the oral medications, the one that's the best tolerated is cimetidine. Very, very interesting. They specifically mention pentosan. Pentosan polysulfate may benefit some, but certainly not all IC patients. It is believed to have a bladder coating effect and remains on the list despite evidence that is associated its use with retinal damage and vision injuries that may be irreversible. Other side effects of Elmiron include nausea, diarrhea, hair loss, elevation of liver enzyme levels. It may take 3 to 6 months to show success. And physicians considering pentosan should obtain a detailed eye history prior to treatment. A comprehensive retinal exam is recommended for anybody with any retinal disease, pre-existing eye disease. And all patients using Elmiron should get periodic retinal exams to determine if changes in their retinas are occurring. And last but not least, they mentioned cyclosporin. Cyclosporin used to be in step 5 of the guidelines, and it is still way back, but what they say here is cyclosporin may be offered to patients with Hunners lesions that are not responding to fulguration or steroid injection. One study found that 75% of patients experienced an improvement in their symptoms compared to just 19% of patients using Elmiron. Success rates are much higher in patients with Hunners lesions, with 85% responding to treatment. All right, so, but as with any medication, the potential for adverse effects is real, and in the case of cyclosporin, it is very high. You can have increased serum creatinine, you can have hypertension, alopecia, cutaneous lymphoma, mouth ulcers, and gout. So, some doctor, Erica, I will get to that. And for those of you on Facebook who are asking questions, please understand that I'm probably not going to see the first 20 minutes of questions. Don't be offended if I don't take your question. I'm going to need you to ask it again, okay? Almost done. Installations. The AUA talks really only about 3 installations: DMSO, heparin, and lidocaine, and how they are often combined together. One big point they make with DMSO therapy is they only want you to hold it for 15 minutes. How many of you have tried to hold it for hours? Right? We all did. I did. I mean, I had DMSO therapy in when? Like 1993 and 1994. We all tried to hold it for longer. We thought longer was better, but the AUA clearly says, no, longer is not better. Longer is actually associated with greater pain. So it's really just 15 minutes. Now, heparin, you might be able to hold longer, and lidocaine, you might be able to hold a little bit longer, but I'll let you read about these in the guidelines. And then they talk about procedures, hydrodistension with cystoscopy, specifically, again, low pressure, short duration. Studies show that it can be considered a treatment, but it's very short term. It may provide relief for 30 to 54% of patients, with the results declining rapidly over time. Fulguration and triamcinolone injection are recommended for Hunners lesion treatment. One study found that 100% of patients treated with fulguration experienced a complete pain relief, and 70% reported reduced or normal urinary frequency. Several more found that a large proportion of patients reported significant improvements in their symptoms lasting. And, you know, you get all excited because you think, well, I mean, that's kind of a new therapy. Maybe that'll fix me. Studies show really modest short-term effects. The dosage starts at 100 units, not at 200 units, which is associated with significant adverse events. And they say, AUA says, Botox should not be pursued by patients who cannot self-catheterize and is contraindicated for patients with impaired bladder emptying. If you cannot empty your bladder easily, you should not be doing Botox, because Botox might make it harder for you to urinate anyway. They talk about neuromodulation. They talk specifically about sacral neuromodulation and pudendal neuromodulation, as well as post-tibial nerve modulation. And one of the things in here that I think is very, very important, neuromodulation may be considered if other treatments have not provided adequate symptom relief. Clinicians and patients should be cautioned that this is indicated for the treatment of frequency urgency and is much less effective and potentially ineffective for pain. So for those of you who have a doctor saying to you, hey, InterStim might help with your pain, the research says otherwise. Do not get your hopes up. Let's see. While these are not FDA, while neuromodulation is not FDA approved for IC, studies with IC patients have shown modest success, though the risk of adverse event is significant, including device failure, pain at the lead sites, stimulation radiating to the leg, and infection. The AUA panel says this may only be effective in carefully selected patients, and the decision should be left up to the clinician and the patient. And then they talked about the ankle stim, a less invasive form of neuromodulation. PTNS is performed at the ankle, requires no surgery, and is administered with a TENS unit and an acupuncture needle. However, the research results are fairly minimal success. They go through surgery. Of course, surgery was step 6. Surgery is rarely used as a treatment for IC, and only in a very small group of patients who have exhausted all other therapies and whose symptoms are directly caused by the bladder. If they have neuropathic pain, pelvic floor dysfunction, these will not improve with bladder surgery. It is best reserved for patients with an end-stage fibrotic bladder, which means a very small, stiff bladder that cannot open to hold urine. Let's see here. Patients who are not good candidates for bladder surgery or at a higher risk of failure are patients who have a large bladder capacity, who do not have Hunners lesions, who have no relief with an anesthetic installation, who have pelvic floor tension, genital hyperesthesia, pain beyond the pelvis, or pain with multiple conditions. And last but not least, and this is the first time I really, maybe this was in the previous guidelines, but they very clearly said major bladder surgery should only be performed by surgeons with extensive experience in IC BPS and who will be dedicated to your long-term care. So I don't remember them being quite so blunt. That's very, very blunt. And of course, they went through the 4 treatments that we no longer use for IC, which is long-term antibiotics, BCG, high-pressure distensions, and systemic glucocorticoids, steroids. The guidelines make no judgment about the role of embedded infection. It would have been nice if they had. I mean, that was literally when I announced the guidelines on Twitter. I was immediately attacked by people who said, who have jumped down the embedded infection theory, where they believe that the great majority of patients have embedded infection. And the guidelines simply do not go there. And they continue to say that antibiotics should not be offered to patients who have already been given antibiotics without effectiveness and who have a negative urine culture. However, this does not preclude the use of prophylactic antibiotics for patients struggling with recurring UTIs and symptoms of IC in between infections. So, so the next AUA meeting is going to be in Denver next year. And the doctor that is kind of leading, the one doctor in the United States that is really working on that, says he's going to be bringing research to next year's AUA meeting. And I said, power to him, power to him. But at this point in time, with the well over $100 million invested in IC research, IC researchers have not been able to establish any connection with IC and bacteria. What they have been able to establish is a connection between IC and virus and IC and candida. And it was our own NALMAP Research Network study who found, in studying the urine of patients who were flaring, that many of you actually have a very, very virulent candida infection. And that data was confirmed by a research study a couple of months ago from UCLA. And it makes sense, because if there's ever a group of patients who are overexposed to antibiotics, which it's going to be us. And when you kill the good bacteria, you create the perfect environment for fungus to grow. But what's remarkable about it is they say that it is a very, very virulent, aggressive, damaging candida. That's why we do next generation DNA urine tests now, because that will tell us if you do have a fungal infection. And then, of course, now we know about virus. We know that the Europeans did find some viral load in patients with Hunners lesions, the polyoma virus. They made that discovery about 5 years ago. And our own National Institutes of Health in the US has actually now confirmed that they did find a very small subset of patients with IC they didn't say Hunners lesions, but a small subset of IC patients do have polyoma viral infections in their bladder. And that makes sense, because we now know that COVID can infect the bladder, which is called COVID cystitis. So when you think UTI, don't just think of bacteria. You got to think about fungus and virus. So let me tell you one thing. I could never have just talked as long as I talked if I were taking amitriptyline or hydroxyzine. I can't imagine doing this with dry mouth. That would be so hard. Rhonda, let's see. Proceed says, one thing I found was estrogen atrophy, and mine should be bladder wall with food sensitivity. Tomorrow I have an appointment with pelvic floor therapist as I'm suffering constipation. Good. Check it out. Rhonda says she drinks a lot of water. But in that she's very sensitive, just like I am. Don't like to take a lot of meds. Julie said, I was knocked out for DMSO. I had blissful relief for 2 days. Very unusual to be anesthetized to have a DMSO therapy. It's normally done as an outpatient. It's not normally not done as an outpatient procedure. It's normally done in your doctor's office. That's rare. That's really rare. Interesting. All right, let me come to Facebook here. You guys, we are broadcasting live on YouTube and Facebook. If I'm looking over here, I'm looking at YouTube. If I'm looking here, I'm looking at Facebook, even though both cameras point to my face. So let's check out YouTube here. Facebook here. Christina says, a hydro and instills ruined you. Well, on the old days, with the high pressure, long duration hydrodistension, not only did we have bladders ruptured, but they actually, in the guidelines, talk about bladder necrosis. Basically, tissue can die. So we certainly, over the years, have had a number of IC patients who have shared that they felt that they were worse after having a hydrodistension. Jessica says, I think I have endometriosis. So if you have super painful periods, you should definitely talk to your gynecologist about it. Go to the Endometriosis Association has a fabulous website. Go over to their website and check it out. Okay, now you guys, I know I missed a ton of questions on Facebook. Do not take it personally. Please ask it again, okay? Elena says, what do you think about hyperbaric oxygen therapy for IC here in Norway? It is approved for radiation cystitis after cancer, but not painful bladder syndrome. I have talked to a lady who had this treatment for other health conditions, but got massive improvement with her IC. The improvement continued after 7 months when I talked to her. She got her life back. All of her food sensitivities disappeared. Yes, yes. We now have a couple of small studies which show that pressurized oxygen, this is what they would normally put you in an oxygen chamber to prevent the bends if you were a scuba diver. And what that does is that pushes oxygen into your bloodstream, and it penetrates throughout your body, and it can certainly have a healing effect. And we certainly have research that shows hyperbaric oxygen therapy has helped some patients, especially patients with Hunners lesions. The challenge with hyperbaric oxygen therapy is it's either in a tube, think iron lung, it's in a long, narrow tube, and you just, so if you're claustrophobic, that's going to be hard. Or if you're in a facility, there might be a pressurized room where you can go in, sit in a recliner, read a book, et cetera, et cetera. Kayleen, hey girl. Linda Laidlaw. Linda, do you have a relative named Doug? I went to school. I went to school with Doug Laidlaw, and he was a brilliant horseback rider. And his mom trained horses. Any relation? I've always wondered what happened to him. She said, I had treatment for Hunners last year, along with hydro and biopsy. You got exactly 2 pain-free days. Euro wants to repeat, but I'm hesitant. Well, how did they treat it, hun? How did they treat your lesions? I mean, the guidelines had one section. See, look. Okay, so these are the guidelines, right? And Lynn, there was one section in there that said, like, if you find Hunners lesions, you treat the Hunners lesions, and you don't do the hydrodistension. Like, you do the cystoscopy first, look for the lesions. If you see lesions, you treat them, and then you stop. I think you should. Let's see. There's a very specific statement. Let me see if I can find it here. It's under. I hadn't seen this order before. It was a specific order of how things should be done. Let's see, is this it? Hold on. Well, I don't want to waste time looking for it. You'll want to look at the guidelines, and I'll have a link to that on our website. Okay. Sherry says, I tried estrogen cream and it burned more. Did you do systemic or just local? So estrogen cream almost always is going to burn when you first start using it. It's not physically burning you. What it means is that your skin is dry. And so it's quite normal for women who start estrogen cream to notice that it has a burning sensation. And the burning might last 5 minutes, 10 minutes, 20 minutes. It might last an hour or two. The more it burns, the drier your skin. Understand, though, that you kind of have to power through that burning for a couple of weeks, and it will go away. It normally does go away because as you give that skin estrogen, it immediately starts to produce mucus. So I went through that. It took about 10 days for the burning to go away for me. Understand also that if you're doing Premarin, for example, Premarin is probably the most popular brand name for estrogen cream. It is associated with more burning and discomfort because it has preservatives in it. I use a preservative-free formula that I get from the Women's International Pharmacy. Kayleen says, installations helped me, but the Hydra tore you up for months, even though your bladder was small. I'm sorry to hear that, you know. It's tricky. Erica says, I take Hyprex, so can I use Preleaf with it? I don't know, hun. You'll have to ask your pharmacist. I don't know. Kayleen says, I got so much to tell you. I was thinking about a Zoom later. But girl, everything is going good. You can't stop shedding happy tears. Oh, everybody, send your love to Kayleen. Yeah, for those of you who've been here, you know, sure, her life has been hard. I'm so glad that things are getting better. Woohoo! Jessica says, what does the wand do? You use a Pyrex glass wand internally through your vagina or through your rectum to actually relax your muscles. So let me get my demo here. Oh, yeah. And Callie just came in. Callie and I did an awesome podcast, another podcast on the AUA guidelines that she'll be releasing on Wednesday. And Callie, I do have the new document, our new fact sheet that I did on it. I can even send you the PDF and you can put it on your website if you want. Or feel free to copy them and adjust them and do your own. All right, so let me get the wand here for a moment. Hold on a sec. All righty. It's a hot summer day here, my friends. It's sundress weather. All right. So just to give you a quick demo of why a wand is important, here's your pelvis, correct? We've got your hip bones here. We got your pubic bone here. On the back, we've got your spinal vertebrae. Then we have your sacrum, your tailbone, correct? And I want you to take note of all the muscles that attach to your tailbone. You see this? So if you have broken your tailbone and your tailbone is crooked, you can almost guarantee that you're going to have pelvic floor dysfunction. The tailbone is supposed to be centered and curved under. So, but I want you to look from the bottom. All right, where are my levators? Okay, I have lost an important muscle. Oh no, here it is. Here it is. So the thing you've got to remember about the base of your pelvis is that it's not protected by bone. So when you sit on a bicycle seat or a saddle, or even you sit for long periods of time, but especially a bicycle seat, you can really see what that would do, because you would just be putting more and more pressure directly on these muscles. And if we put the levators here, and these are the female levators, not the male, you can definitely see how sitting on a bicycle seat for a long period of time would cause a problem, right? But the other thing you've got to really understand about your pelvic floor muscles is that they're flat on the bone. You see that? It's not like they're up in the cavity. They're actually flat on the bone. And so if you want to try to do physical therapy on your pelvic floor, you're not going to be able to reach them from outside. The only way to reach them is with a finger in your vagina and rectum. And so look at this. So you can see now that I can reach these muscles that could be part of the problem, right? But see, it's easy to do on a model. You're not going to get this amount of penetration yourself, unless you're a contortionist. So we often have to use a glass wand, and which is what I do. You can use a glass wand to work on these muscles. You see that? Works beautifully. And I think it's really interesting because first it was my left side, and then after I hurt my back, it was my right side. And now that I have a little tiny lift in my right foot, because we're trying to figure out, my physical therapist and I, why I'm really tight up here, like my TMJ is crazy. So I'm really tight on the right side from the waist up, and I'm really tight on the left side from the waist down. And that is because I have scoliosis. And so my left hip rotates this way and my right shoulder rotates that way, which is why if you see me turn this way, sometimes you see my shoulder jutting out, right? So anyway, we've just really been working. I'm very dedicated with him to try to understand what's driving all this TMJ for me, because I haven't slept in my bed in almost 2 years. I'm sleeping in a recliner right now. I want to sleep in my bed, for God's sake. And so what he found is that my right leg was about 1/4 of an inch shorter than my left leg. And so I've got 1/4 of an inch lift in my shoe. And what's interesting now is that my pelvic floor pain is on both sides now, which I consider good. I consider that to be a good thing. Making progress. Very, very determined to understand this crazy body. Rindy says, I'm an IC sufferer for 21 years, saw a new urogyna Thursday. She said, I've been through all lines of treatment and simply recommended InterStim. Recommended your InterStim be replaced by the Axonics device and add marshmallow root to my routine. You take 1 Urobelt a day, try pelvic floor physical therapy. I'm unsure if I want to replace the InterStim. Not once have you been offered pain management. You're terrified to ask in fear of being labeled. I don't know what else to do. I live in pain every single day. Yes, I want to get to the root cause. I need help being able to function and provide care for my children and have better quality of life. So Rindy, number one, totally understand. It's incredibly frustrated that in the environment that we have right now, that it's very difficult to ask for pain care. I understand your fear of not wanting to be labeled. As I've said before in previous meetings, one way to get through this conversation is to talk about your functionality. So instead of walking in and saying, I need pain care, walk in and say, doctor, these are the things I cannot do that I really need to be able to do. I cannot sit in the car and wait for my child to pick up my child at school. The pain is excruciating. Or I cannot bend over to pick up our washing, or I cannot sit at work. If you explain to your doctor the limitations of your functioning, and then you ask the magic question, what can we do to help me function so that I can do what I need to do? And you let them bring up the concept of pain management. And then the other thing you have every right to do, and I like your attitude here, is just, you can also just be very blunt. I want to get to the underlying cause. I mean, we've been treating this for 21 years. I'm not better. The American Urology Association guidelines say, if you're not responding to therapy and you're getting worse rather than better, then let's take a step back and revisit the diagnosis. Did we miss something? Did we miss something? And Rindy, I really want you to go back 21 years ago to when your symptoms began. Like, what do you think triggered your symptoms? What do you think your subtype is? If you were talking with me on the phone and we were doing a little bit of a coaching session, that's where we would be spending a lot of time, is trying to understand what happened 21 years ago. And I'd be happy to do that with you. Maybe we can do a Zoom if you wanted to. But I'd be happy to talk with you on the phone. And we want to, I think, kind of buckle down on trying to understand your subtype and focusing on treating your subtype. Does that make sense? I would also want to know, have you tried the supplements? Because the supplements are remarkably helpful. If you have multiple pain conditions, making sure that you try the PEA is important. Now, you guys, so we've talked about palmitoyl ethanolamide. We had a research study in 2019 that showed that it was remarkably successful at reducing pain, especially in nerve-driven pain. And people have asked me, what do I take? That's what I take. I take Peora. Do I have a bottle of it here somewhere? It's the blue bottle. And the reason why I started taking it is I just had a lot of skin sensitivity, which is very common in patients with central sensitization, IC subtype 5, chronic overlapping pain conditions. And so even though my IC is completely controlled, my IBS is completely controlled, my vulvodynia is completely controlled, my TMJ is out of control, which is one of the chronic overlapping pain conditions. My biggest day-to-day issue is just irritated skin. And so I haven't taken it for a couple of days. I don't know. I just kind of was curious. I wanted to see. I mean, I've been taking it for 2 years. Felt incredibly good with PEA. Almost all of my skin sensitivity went away taking simple PEA. Haven't taken it for 2 days. Woke up this morning itchy, with my skin prickling again. So tonight I'm going to take it again. So again, Rindy, listen, give me a phone call this week. I'd love to talk to you. This is going to be a busy week for me, just so you know. Tomorrow is my day off, although I will be here just working on other stuff. Tuesday, I have to take my dad to the cardiologist, and so I will be gone in the afternoon. And then Wednesday, my mom is having oral surgery, and I will not be available all day on Wednesday. I should be available on Thursday and Friday. Erica says, my private urologist wouldn't prescribe Elmeron. He said it was dangerous, could make you blind. Yes, we have that research now. Elmeron is absolutely, pentosan polysulfate is strongly associated with eye disease now. Rhonda says, wow, I haven't been able to sleep in my bed either, Jill, for a long while. I have too much pain in bed. I had trouble before I really dove into muscle work. I always had left side sciatica pain, and I would sleep on my back, and my cat would be laying on me, and my left SI joint would be screaming in pain. Thankfully, that's all gone. So, hey, the Sketching Doro. Hey, Jill, greetings from Germany. How do you manage your symptoms? Are you doing good? I'm doing great. My bladder, aside from the fact that I'm older now and my skin is just getting drier, more prickly, my bladder's, 99% better compared to where it used to be. My muscles are a work in progress. I'm really paying attention to when they get tight. I mean, I'm not IC subtype 1 Hunners lesions or subtype 2 bladder wall driven. I am primarily muscle driven. So it's really my muscles that tend to drive my symptoms and my nervous system that drives my symptoms. So I have to work on my muscles consistently, several times a week. I really have to work on it. And remember too, for those of us who we go to physical therapy and we feel better, but then the muscle tension comes back. That's usually because there's a bony structure abnormality, that there's a problem with the bone that's putting pressure on those muscles. And in my case, it's my SI joint, my scoliosis. So it's just something I really always have to work on. Yeah. So how are you, hun? How are you doing? So you guys, again, when I'm looking over here, I'm looking at YouTube. When I'm looking here, I'm looking at Facebook. Veronica says, what is the recommended dose of cimetidine? Let me see if I put it in my fact sheet. If I didn't, it's definitely in the guidelines. I did not. Maybe I should add that. Whoops. Let me find it here. Okay, cimetidine, 400 milligrams twice daily was one study. 2 observational studies did 300 milligrams twice daily or 200 milligrams 3 times daily. So we've gone from 300 to 400 to 600 milligrams per day. No adverse events were reported. So based upon that, really what they say is always start with the lowest dose. So based upon this, your lowest dose would be well, let's see. Well, 600 milligrams total a day or 800 milligrams total a day. Sketching Dora says, great to hear that. You're such an inspiration for, thank you, honey. I'm suffering from urge again after it disappeared for 2 years. Still don't have an IC diagnosis yet, but will visit a specialist soon. Look to the quality and health of your skin. Women, you got to remember, if your symptoms get worse as you get older, we always want to consider the role of estrogen atrophy. Melissa says, a friend of mine has IC and recently got COVID. He's getting a severe flare, frequency, urgency. What do you recommend for him? That's very common, Melissa. Very, 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 very common. We call this COVID cystitis. And I built a whole website on it, covidcystitis.org. covidcystitis.org. You know, basically it is an inflammatory response with that cytokine storm that happens with COVID infection. I think 75% of IC patients in our study who got COVID reported going into a remarkably severe flare, moderate to severe flare that can last for a couple of months, maybe up to 6 months. And the challenge with this is it made the bladder all the more sensitive and vulnerable. So you kind of, if you had COVID and you're dealing with COVID cystitis, you're gonna have to go right back to the basics, protect your bladder, follow the IC diet, do everything you can to protect that tissue and calm that tissue down. One of the challenges with COVID is that some doctors want you on very, very high levels of vitamin C. And of course, high levels of vitamin C are going to irritate the hell out of your bladder. And so you might have to do a buffered vitamin C or do some pre-leaf with that vitamin C to reduce the acid of it. Kayleen says she can hold heparin longer than 45 minutes. The lidocaine makes me too numb, though, so my urethra has a mind of its own at that time. It does. Christina said you had 2 years of Interstim with zero pain relief. Well, Christina, that's because Interstim is specifically not approved for pain care. It has never been found consistently helpful with pain. And the AUA guidelines that they just released last week specifically say that. And let me go to that section again. And you guys, you will be able to download our fact sheet on these guidelines probably by tonight, if not tomorrow. I finished them up last night, yesterday. Neuromodulation. So here we go. So Christina, this is a specific quote from the guidelines. Clinicians and patients should be cautioned that this is indicated for the treatment of frequency and urgency and is much less effective and potentially ineffective for pain relief. And we've known that. We have known that. If you look at all the materials with the FDA approval, if I remember correctly, they specifically said, do not expect it to help with your pain. Yeah, some patients might have gotten some pain relief, but that's certainly not consistent. Lori says, can you repeat again the next generation testing for Candida? If you go to bladderhealth.org, bladderhealth, HEALTH.org, I built a whole website on next generation DNA urine testing. So you can watch videos on that to see how other doctors have used it. Next generation DNA testing is considered the next phase of urine testing. Some people see it as controversial. Others, doctors, especially infectious disease specialists, a lot of the COVID testing uses next generation DNA techniques. It is absolutely the future of urine testing. There's no doubt about that. That was a big speech on that last year at the American Urology Association by Dr. Curtis Nickel. Sketching Dora says, where can I find the IC diet, and does it work for everyone or is it very individual? You can find it right on our website, icnetwork.org. The IC Network website, it was the first website ever built on IC. We built it years before anybody else built their website. We were rated #1 on the web by Harvard Medical School and the University of London for the information that we have on our website. And we spearheaded all of the diet information. So just going over to the IC network. Does diet work for everyone? It depends upon your subtype, hon. If you got Hunners lesions, you're going to be diet sensitive. If you're bladder wall driven, you're probably going to be diet sensitive. Are you pelvic floor driven, you probably won't be as sensitive. So we're all individuals. And you can't, and guys, I mean, it's always worth a note of caution here. Now listen, you can't kid a kidder here. I've talked with thousands of you over the years. I'm not lying. I've talked with thousands of you. And just like 2 weeks ago, I was working with a patient 2 or 3 weeks ago. She was having long-term consistent bladder pain. She's getting very, very frustrated. And her symptoms started as she got older. So she was clearly somebody with estrogen atrophy. And I go, so do you know about the diet? And she goes, yeah. Are you following the diet? She goes, yeah. And I go, like, are you really following the diet? Do you drink any coffee or soda? And she goes, yeah, you caught me. I'm like, all right, spill it. How are you cheating? And she's like, I have 3 Diet Cokes a day. That's like, you can't do that. You can't do that. You cannot do that. Your bladder is unable to defend itself because of the loss of estrogen. Your bladder is dry. You're pouring the equivalent of formaldehyde into your bladder 3 times a day. Formaldehyde is broken down into formic acid. I always get that confused. So it's a specific process for aspartame and how it's broken down. Anyway, it ends up with formaldehyde and formic acid, but it's a 2-step process. Okay, listen, you can't do that if you've got bladder symptoms. And she's like, yeah, you caught me. And I'm like, yeah, I got a lot of you guys over the years. You can't kid a kidder. Hi, Bonnie. Christina said, I did 6 months of instills, never had pain before that. What kind of instills did you do, hun? What'd you do? Bonnie says, can my daughter inherit IC? No. The only thing that remember, we don't look at IC as a bladder disease anymore. It's not like there's a disease that's inherited. We think of IC as a chronic pelvic pain syndrome. Why? Because structures outside of the bladder are involved. So, we just don't have any evidence that Hunners lesions are passed between generations. Hunners lesions might, and for many of us, simply be a viral infection or the result of an injury. Pelvic floor tension, it should not be inherited. What can be inherited is nerve sensitivity. I mean, I'm a redhead. I have an extremely sensitive nervous system because I'm a redhead. I'm a double recessive redhead. I have very sensitive skin, and I have a very sensitive stomach and a very sensitive bowel and a very sensitive bladder related to that skin sensitivity. And my sister had that, my mother had that, my grandmother had that, et cetera, et cetera. So, but that's not a disease. Every tribe had somebody who was sensitive, who could taste the water and smell the water or smell the food to make sure that it was safe. Sensitivity is an evolutionary priority. It's important to have people who are sensitive because we're the ones who smell the fires first. We're the ones who, can tell if the water is good or the water is bad. That I care for my elderly parents. I came home, I don't know, about 10 years ago when they were in their 80s and they were cooking bad bacon. And I walked in and I was knocked flat by this awful smell. They couldn't smell it. They would have eaten this terrible bacon. And so it's okay to be sensitive. It's just hard because humanity is not kind to those of us who are sensitive. The word sensitive is weaponized. A lot of people say, oh, you're sensitive, get over it. Well, you can't get over how you're built. I can't get over the fact that I'm a redhead. I love being a redhead. I love being sensitive. I do. It's who I am. I mean, it's very, very interesting. All right. I just wish that somebody in childhood had said, as you think about a career, you have to find a career that fits you physically, mentally, emotionally, and intellectually, right? And kind of when we're growing up, at least when I was growing up, it was to be successful, you were either supposed to be work in the big city, work for the government. We're all scientists and academics and teachers in our family, or government employees in our family. We didn't have any business leaders in our family. So I grew up with, you know, you have to be a scientist or you have to work for the government to be successful. And, you know, I tried it and it didn't work for me. I worked in the city. I worked for the feds. The work was easy. Could have done it with my hands tied behind my back, but my body was miserable with the drive, with the smells. I don't like being in a city. I like being in the country. I need a quieter environment. You know, I like having the sunshine. I like seeing the birds flying. You put me in a city with all these noises and smells and sounds, it makes me crazy after about 24 hours. So, you know, I just wish somebody had said, you need to find a career that works for you. And it's not other people's expectations, it's your expectations. What makes you feel good? And for a lot of you who have lost your jobs, like I lost my the job that I was doing when my IC started, don't look at that as a failure. Look at that as a, okay, this is a great opportunity to find a better job that will match me perfectly. So for those of you who are a little bit tied to a restroom, you know, that's the gift of COVID, is we've all learned we can work from home, and we've learned there's a lot of jobs we can do from home. And I have on our website a beautiful article written by a writer about a lot of things that you can do from home and work from home that maybe ICers, you might feel more comfortable doing, right? Or if you have IBS or whatever. Hey, Marcia, my new primary care insists on giving me statins for my cholesterol or your low density lipids. I told her that they put me in a terrible flare. She doesn't believe it. I guess I will email her the multitude of articles that clearly state statins cause terrible pain. Don't know what else to take. You know, my mom is in has some heart failure now. She'd probably been in heart failure for years. We just didn't know it. Now we know it a little bit. I mean, it's very, very mild, but let me tell you, we have nailed her aorta has severe atherosclerosis, but it's not, there's no aneurysm. It's working for her. But holy crap, have I buckled down on, we do not use butter anymore. I do a coconut, a butter alternative. She used to love milkshakes, and because she doesn't like to drink in the summer anyway, I used to feed her a lot of milkshakes. Oh, not anymore. I can make a milkshake with low-fat ice cream, non-fat milk, and caramel, and she doesn't even know she's not having a Baskin-Robbins milkshake anymore. So it's amazing what you can do when you know, when you kind of give up the things that you've clung to, like butter. In our family, butter was huge, but now we're almost butter free. Not quite, but we're getting close. Mary says, burning made my bladder crazy from estrogen cream. Yeah, honey, that's just because your skin's dry. Your skin is dry, but the burning goes away. You know, I understand that fear. The last thing you want is more pain. And for some of you, when you use estrogen cream for the first time, it burns like hell. But you have to work through that, because your skin will immediately absorb that estrogen and it will improve the quality and health of that skin. So Linda had her Hunners lesions treated with steroids and cauterization. Okay. Well, Hunners lesions are known to recur. It would not be unreasonable to actually have the doctor look again and see what's going on with that. And remember too, now we have other things that we're focusing on, you know, like your tight pelvic floor muscles. And it would be absolutely reasonable to maybe do a next generation DNA urine test to see if you have any virus in your bladder. And we can give you that research. That research is on our website, and it's from our own National Institutes of Health. Nobody's making that up. So if you want more information on that, just reach out to me this week. Becky is 34 weeks pregnant. Congratulations, hon. Sherry says she'll get an eye comfort mattress. Eye comfort. I don't know what an eye comfort mattress is. Let me look. I love my mattress. It's really old, but it like works for me. It used to work for me, not anymore. Oh, a cool, comfortable sleep mattress with gel. Ooh. I'm very careful with foam. I don't think I could do that, hun. You know, I'm really sensitive to the smells that these foams push off. That would be kind of hard. Anybody have a purple mattress? Those purple mattresses? Becky says PEA is great for me. Yeah, good. But she stopped taking it when she got pregnant. Kayleen said, my surgery went really good. Oh, holy hell. Kayleen, we got to do a Zoom. They did find a lot of endometriosis on my bladder, my uterus, the ligaments, the ovaries, the fallopian tubes, and the peritoneum in front of the uterus and bladder. The uterine polyp is gone. There's barely any blood anywhere. She only made 2 incisions to avoid the scar tissue. I'll admit I'm in a lot of time. Well, of course you're in pain, hon. You just had surgery. My vagina is a little sore, but you got an IUD. Interesting. I feel my hormones are already balanced, and it's making my bladder feel better. I'm excited for pelvic floor physical therapy next month because my pelvic organs were so messed up that it made me stand up in a healthy way. I need to retrain my back. I'm so excited. Oh, my God. Oh, honey. Oh, I'm so, oh. Oh, I wish I could just give you a hug right now. I am so, girl, you did it. You did it. You got through it. And it was successful. And look at this. It was never in your head. And all those people who told you that it was, they were shit. You have the proof. It was all there. Oh, this is, now listen, girl, you're recovering now. And you can, and it's going to be a slow recovery. You just had major surgery. So you got to be really gentle to yourself. Do not push yourself aggressively. You're going to have to give yourself several weeks for things to really, really calm down. And the pelvic floor physical therapy, you're going to have to go really slow, girl. Come on, you got to go really slow with that. But this is such a huge step for you. This is fantastic. Did you go home the same day? Or did they keep you overnight? Oh, I could just, like, I have tears in my eyes for you. I'm so happy for you. Erica says, I've got chronic fatigue, fibromyalgia, TMJ, along with other diagnoses. Okay, Erica, that puts you into IC subtype 5, central sensitization. That means you have multiple pain conditions that are driven by your central nervous system. And so you've got to focus on central nervous system strategies. There's a fabulous research group called the Chronic Pain Research Alliance. Look it up, Chronic Pain Research Alliance. All the research is pointing to the amygdala in the brain as being stuck in fight or flight. We call this a central nervous system maladaptation. I got the IC and the IBS and the vulvodynia and the TMJ2. I don't have the chronic fatigue or the fibro, but because we're all different in a way. But the underlying connection is your central nervous system. So you're going to be focusing on things that will calm your nervous system, especially anxiety. Because almost all of us who have chronic multiple pain conditions have anxiety disorder. And we got to nip that sucker in the bud, because that's one of the things that's keeping you in fight or flight. When you're in fight or flight, your pain intensifies, your muscles get tighter, et cetera, et cetera. And so, Rindy, you're in the same boat. So Rindy says, I have more than one subtype. I'd love to talk with you one-on-one. I also have fibro, TMJ, degenerative disc disease. You're now developing skin conditions. You got food poisoning that legit almost killed me, and mono, and symptoms started. The mono is important because we've also found the Epstein-Barr virus in some patients. diagnosed at 18, would love to talk to you. So anyway, Erica says, can we get PA in the United Kingdom? You know, you should be able to get it from other companies. Just look, palmitoyl ethanolamide. I'm sure you, I mean, you know, when you guys left the EU, that made it hard for everybody who's trying to ship to the United Kingdom. We haven't been able to since then. If you have a friend in the United States or a friend in Canada, I can ship it to them and they can send it to you, but I can't send to the United Kingdom right now. We do not have VAT registration, and we are required now to collect VAT at the time of sale. We don't have software that can do it. I mean, we'd have to register with the government, which takes months, but then we're required to collect the VAT and send it monthly. And we do not have software that can do that right now. So if there's listen, even if you have a friend online that you've met in the United States, if they're willing to be the middle step, we can ship it to them and then they can send it to you as a gift. But we cannot send it to you with a receipt. We can't. We cannot do it. Becky said, I had a similar but different experience. Jill, my family wanted me to go into law, medicine, or business, and none of those things were right for me. Those were the only options for success that were presented to me when I was a teen. Turns out the library is really where I shine. I wanted to sing in junior high. I wanted to do chorus. I mean, I was in a couple of musicals in college and in the summer, and I love singing. I don't know if nobody ever tells me. I mean, some people have said I have a good voice. Others have stayed neutral about it. But I wanted to take chorus in junior high, and I wasn't allowed to by my family. I was required to take Spanish in junior high and high school to ease my way into university. So do I regret that? No. You know, it is what it is, but if I had children, I would not do that. I would try to let them try lots of different things to find their place. Sherry says, nothing will hurt you when you lay on an eye comfort mattress. It feels like you're floating on air. You're also sensitive to smells, but oh, really? It never bothered you? Okay. Interesting. Well, maybe, okay. I will remember that. I will remember that. I mean, right now we're just trying to, if I lay flat on my back, my jaw on my left side starts to dislocate. It's better. I can now lay on my back on my couch for a couple of hours at night, but I haven't been able to lay flat on my back on a mattress in almost 2 years. I can lay on my right side. I can't lay on my left side, and I can't lay on my back. Becky got the purple mattress. And did the purple mattress smell at all? I bought a couple of purple cushions, but I sent them back. I didn't like them. I mean, they smelled to me. Randy said, I wish I could take you to the doctor with me to help me make it scent. Randy, girl, we will rehearse. We will rehearse on the phone. Okay. Judy says, can you take D-mannose with antibiotics? I don't see why you couldn't, but ask your pharmacist. Remember, I can't give you medical advice. My job is to educate you, inform you, open up new doors, get you to read more, and then kick you in the butt and get you back to your doctor with better questions. So I don't see why it wouldn't. It's just a sugar. It's a sugar that the human body doesn't use. But I think if you have any doubts at all, you should talk to your pharmacist, do your research online, or ask your doctor. It's very common for women with recurring bladder infections to be taking D-mannose or Prevent or Allura, using a PAC product, a proanthocyanidin product, or D-mannose have been shown to help reduce recurring UTI in some women with estrogen atrophy. So Prevent is, let's see, here it is. This is what Prevent looks like, but they have a new label that's white. But anyway, prevent is kind of the one that we have in our shop for people who are struggling with, for women who are struggling with really recurring UTIs. I mean, it happens. If you have estrogen atrophy, then it's easier to get infections. And as we get older and we go through menopause, the pH in our vagina changes. It becomes more friendly to bacteria. And so there absolutely, it's a group of women who get recurring UTI, sometimes one a month, sometimes one every 3 months. If you have 2 infections in 6 months, 3 infections in a year, you are in the complex UTI group. And generally, what the research shows with that, and I attended an amazing lecture on this taught by Dr. Anthony Schaefer years ago at a National Institutes of Health IC meeting. He explained that number one, a woman with a recurring infection is never diagnosed with a simple UTI. You are always diagnosed as a complex patient. And what the research showed is that 24 hours before the bacteria arrived in the bladder, it was living quite happily in the vagina. And so that then the researchers then wanted to consider, okay, why has the vagina become a safe haven for bacteria? And the answer went right back to estrogen atrophy. So generally in women, postmenopausal women, in addition to giving you antibiotics, they will also give you a topical estrogen cream to use vaginally to improve the defenses in your vagina and hopefully improve the quality and health of your skin so that you're not so vulnerable. And again, when we're thinking about what else you can do, it's going to be D-mannose or prevent or allura. These are going to be the top ones. Got to be really careful with cranberry juice, cranberry extract. They can be really strong. These proanthocyanidins come from cranberry, but there's no acid in it. So this is when, you know, that whole natural approach nutrition product line, a bladder builder, bladder rest, all these, their top supplement is this by far. This is huge. Rhonda said, just heard you. I can't sleep on my back and only on my left side. I thought it was just me. It's crazy, right? It kind of scares me because, like, I want to travel. Well, once COVID is over, I'm not traveling now. But, like, I'd love to just go spend the night down at a little spa that we have. But I don't know if I can sleep in the bed right now. I think that the stress of COVID and caring for my parents it just got too big. And that's really what triggered my TMJ. We all react to stress in different ways. And I still catch myself holding my jaw really tight. If I open it, my jaw swings this way a little bit. It's not always up and down. My lower jaw slides a little bit to the right. I don't think you can see it. It's pretty small, but it's there. Amy says, Jill, I'm still not sure if it's actually my bladder. I'm doing all the therapies and nothing is helping. I need to find another doctor. So if you're number one, Amy, this is what we want to know. Number one, if bladder therapies are not working, if you're not particularly diet sensitive, and or if you don't have pain as your bladder fills with urine that is relieved by urination, then we absolutely got to look beyond the bladder. And at a minimum, you need to have a pelvic floor assessment, and let's see what's happening with your pelvic floor. Susanna said, I had no idea you like to sing. I was in show choir and chorale in college. Once you do it, you always love it. I think there are maybe some apps online. Yeah, I do. You know, guys. So like, and Janice, I don't know if you're listening or not. My sister Janice often listens. My dad, when we were kids, always woke us up singing. And it would be, you gotta get up, you gotta get up, you gotta get up in the morning, right? Something like that, very World War II-ish. And he still does that today. And it's one of the things I love about him. And so I was up early. I was up before anybody else. And I tried to wake my mom up. She didn't want to get up. This was like at 11:30. she sleeps late. So I sent him into work and he sang her awake. It's so sweet. It's so sweet. He could, he almost can sing opera. I mean, when he was younger, boy, he could belt it. And he's still pretty good. Kayleen said, exactly. I labeled myself as a fighter and a lover. I fought for 17 months and finally found a perfect doctor. I want to get in the face of all the ER and OBGYN doctors I have here at home that told me I'm all somatic. You got to tell your story to a newspaper, maybe for IC Awareness Month. My surgery was delayed by 5 hours, so my blood sugar dropped quite a bit. They did kind of rush me in. I had 5 doctors working on me, but I'm so glad it wasn't so bad that my urogynecologist had to pop in, and I don't need a colorectal surgeon. They didn't keep you overnight, but you stayed in a guest house overnight to be safe in case you needed to come back to the ER. Oh, good. I'm having a few problems with pain management here at home because it makes me so fuzzy, but then my incisions are throbbing. I don't want to go through an opiate-induced constipation. I understand. Little amounts. When I had my hysterectomy, I did only the first day, maybe the first 36 hours, I did a half a Norco every 4 hours. And by the third day, I was doing a quarter of a Norco a couple of times a day. And then by the, just getting through that post-op pain. And you're what, at day 4 now? Yvonne says, I went on a trip with family, had to stop every 30 minutes, and you still soak through pads. You're so over it. So you have you have incontinence. I gotta say, to be perfectly honest, I have been doing more things like this, right? Just kind of running in place here at my computer or jumping like that. Trying to get some life back in my legs. And I gotta say, my 61-year-old pelvic floor muscles are protesting a little bit. I used to love to run upstairs. Like I ran up Diamond Head in Hawaii. I love to run up hills, but haven't been able to do that with COVID. And so like everything is all weak now. I feel like I need life in my bones. I need some energy in my legs. Marcia, diagnosed with rheumatoid arthritis last week, maybe lupus. Your LDL, C-reactive protein, everything out of whack, going to do them in June. Also diagnosed Raynaud's. Does this make me central sensitization? Trying to get into EMDR therapy. I know the stress from the last few years has done it. I mean, maybe yes, maybe no. I mean, it kind of puts you into a unique category of autoimmune cystitis, and we don't have a lot of information on that right now. We're trying to develop some information for patients who appear to have an autoimmune connection, but that's just baby steps right now. In fact, I sent a letter to all the IC doctors that I know months ago and said, so what are your recommendations for patients with autoimmune disease? None of them responded. Like the first time in 20 years, I didn't get a single response from one of my letters. Normally I get responses from a couple of the doctors. And I think that's just because they haven't really talked about it yet. But yeah, we all have to get the stress under control. I mean, we are living in difficult times right now, and it's taking a toll physically, mentally, and emotionally in every single one of us. Every single one of us. Myself, I was thinking about that this morning, and I was kind of catching some negative thoughts going on and feeling lonely again, right? We go through these moments where there is a loneliness in our lives for many, many different reasons, and kind of nipping that in the bud and just stop it, Jill. You're exactly where you're supposed to be, right here doing work you love to do. And I just turned on some happy music instead, you know, to get my brain moving in another direction. You know how you have those days where you're just like very thoughtful, kind of dwelling a little bit on your life? And it's just so important that we step away from that and focus on what can we do today, right now, at this moment, to feel better. What can we do? Get up and move around. And I just rather than feeling sorry for myself, I just got up and started doing stuff. And I did everything I needed to do, which is good. And I feel good. I feel good about what I've done today now. Amy said, I had a pelvic floor assessment. I'm currently being careful with diet because I'm too scared. You have I mean, listen, don't be afraid to eat. You can eat. There's a lot of foods you can eat. You know, but it's a reckoning for patients who have lived on junk food and fast food. This is a reckoning. It's just like you learning, hey, your diet is not particularly healthy. So for that patient who does drink massive amounts of coffee or soda and they don't drink water, that's not healthy. And so we have our IC diet over on our website, Amy, and there are 3 categories. Bladder friendly, try it, caution. You're probably going to be able to eat everything in the bladder friendly and almost everything in try it. It's the caution foods you got to be the most careful of. But just take time, you know, go down to your basics, the things that you know you love and your body likes, and start with those, and then just slowly try new foods every day, and let's go from there. I'm one of those people where, you know, food, because I had such severe IBS in my 20s, I was never one of those people that, and I don't have IBS anymore, guys. It's completely controlled. It's gone. I can't even remember the last time I had an IBS flare. I mean, it's been a decade, maybe 2 decades, 15 years, maybe. You know, food was never my friend for a long time. It took a while to figure out it was the freaking oatmeal I was eating, because I'm intolerant to oatmeal and chocolate, and I'm absolutely intolerant to chocolate. Both of those mess me up bad. So the other thing you could ask for maybe is some food sensitivity testing. ALCAT, A-L-C-A-T, ALCAT food sensitivity testing, to see if there's any other weird foods that you might be, you know, struggling with. I had a doctor say to me, eat oatmeal every day. I ate oatmeal every day. I was sick every freaking day. And not just a little sick. I mean, laying on the fetal position in my bed or on the bathroom floor sick. Not having a clue that it was the oatmeal that I was actually allergic to that was causing a lot of the problem. And a lot of you, it's so interesting that oatmeal sensitivity is actually not unusual in the IC patient population. I've worked with several patients who have exactly the same oatmeal sensitivity. Go figure. So in the end, it's about doing kind of an elimination diet and trying to find the foods that work the best for you. So yes, oatmeal is on our bladder friendly list, but it never affected my bladder. It affected my bowel. And again, Janice, if you're listening, it was my sister who changed my life when she gave me a little book, which I think I still have on my bookshelf somewhere. Let me see if it's here. Look at this. My sister gave me this book, The Best Guide to Allergy, when I was like 28 years old. And this is the book that got me started on figuring out why I had such bad IBS. And literally the first thing it said was stop dairy, which I had already stopped. I already knew that dairy, I just felt very crampy when I was eating dairy back then. But the second thing it said is stop all the grains but rice for 3 days. 24 hours after stopping oatmeal, it all disappeared. It disappeared. And then you reintroduce the grains back. So I introduced wheat in first. I was fine. I introduced corn in. I was fine. Introduced oatmeal in. It was catastrophic, right? And it was a simple, simple book. So education is power, my friends. Education is power. In fact, here's the chapter right here on food allergy. The other thing that was making me sick back then was Christmas trees. Christmas trees. Several years in a row, it's just sick as a dog at Christmas. And one reason was because for Thanksgiving, we always got a 2-pound box of candy, C's candy. And every night through Christmas, we all got to eat one piece of candy. And guess what? Chocolate gives me bowel spasms. But Christmas trees gave me bad headaches. And this book talks about Christmas tree. Here it is right here. What about Christmas trees? Christmas trees cause allergic symptoms in many people. The most common sources of difficulty are the airborne pollens and molds that are in the trees that remain there after they've been cut down and stored. A person who is sensitive to these pollens and molds will come into close contact with them when a large moist tree comes into the home. The heat of the house helps to release the inhalant substances into the closed indoor environment, and thus a family recreates a specific pollen and mold season for a few weeks in December. Studies have indicated that a specific allergenic chemical, terpene, is released by the tree itself. This substance directly causes allergy symptoms and discharge and wheezing. People who switch to artificial trees no longer have the problem and remain well. There you go. Thank you, my dear sister. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you for being such a wonderful sister. I'm so blessed. Shauna says, hello, everyone. And Jill, I'm in bed with a flare today. Always so grateful for your live streams. I've been doing hormone replacement therapy for 3 months as hormone fluctuations and food are my root causes. I've been doing really well, though, the last few weeks. Heard it can take 6 months for this to take full effect. Anyone else out there doing HRT and having any advice? Well, what kind of flare are you having, hon? Are you having a bladder wall flare or a pelvic floor flare? I'm concerned that you're in bed. I mean, it's okay to be in bed with a heating pad reading a book. In fact, I fully intend to read a good book after we're done. I just started one. But have you been stuck in bed for a couple of days? And what's your symptom? What's your symptom that's of this flare? Is your bladder screaming or is your pelvic screaming? I mean, tell me about the flare. Yvonne says, Jill, have you tried OMT therapy for my TMJ? I don't know what that is, so obviously no. What is OMT therapy? Let me look it up. Yes. We have been doing, my physical therapist is awesome. I mean, like I'm like 80% better than when I started 6 months ago. And he does inside my mouth and a lot of work here and a lot of work here. So yes. The problem is gravity. I mean, so when it started happening, when I was laying in bed, my jaw would dislocate, or just like 90% dislocated, and you'd jump up out of the bed, and you just go try to get your jaw back in the right position. That hasn't happened in months for me now, but I click. I get little clicks on my left side, which is way better, but ultimately in the end, this side is really tight. And what's interesting is, so I'm laying on the PT table, and so he's doing the therapy up here, right? And he's touching different parts of my brain, and then he has me move my knees to the right, and it immediately tightens up the right side of my neck. And so we're really working on fascia. And he goes, Jill, this is really being caused not up here. It's being caused down below. we have to figure out what's happening, the mechanics of what's happening that's causing all this accumulated tension on the right side of my body. He's fabulous. Best physical therapist I've worked with, who's really helping me understand this crazy body. So Kayleen had her surgery on Thursday. So you're just your third day out, Friday, Saturday, Sunday. Woo! I'm so, you said you just missed the live stream. You were so loopy. Hey, Kayleen, you got to find the video I did. I think I still have it on YouTube. I filmed a live like 2 hours after I got home from my hysterectomy. It was not pretty. It was not pretty. It was just, I'm here. I'm here. I just want you to know I made it. I think I'm okay, but the bed is spinning. I tried to film a live stream. It was so funny. I think it's still on YouTube. I think it is. Bonnie says it's dairy for her. Yeah, I don't do a lot of dairy. I really don't. I've been doing mocha mix for years. I use that for everything. Shayna says, bladder is screaming. This happens every 12 days. You get bladder pressure and urgency. You're 100% sure it's hormonal. But ever since you started hormone replacement therapy, it's made my cycle more active. I'm perimenopausal, 50 years old. You also get burning mouth syndrome, right? Okay. But that's always happening when you get a flare. So I know it's all hormonal. Yeah, for anybody who doesn't know, burning mouth syndrome, I've had moments of that too. And I have to say that the Peora, the palmitoethanolamide has been incredible. But I have had moments when my tongue has gotten very, 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 very painful. And I feel the littlest things, just a little tiny indentation on a tooth. My tongue will play with it forever. I can't stop it. I have to wear wax. I have wax in between two teeth because my tongue plays with it and gets irritated. There are absolutely there is a small subtype of patients who, from day one, they're driven hormonally. For some of them, their flares happen when their estrogen levels are high. For others, their flares happen when their progesterone is high. And it's maddening. And all I can tell you is that when they finally get their hormone levels corrected, they're better. They're much, much better. So that's, hopefully you're on the way to that. Hopefully you are on the way to that. Kayleen says, can we schedule a Zoom for midday tomorrow? I would say tonight, but I'm so tired. We can try, hun. I'm not sure what's happening. I mean, tomorrow is kind of my day to just like deal with whatever has to be done. I'm usually cleaning the house and all that sort of stuff. But let's try. I'll give you my cell phone if you want. Let me email you my cell phone number, okay? Here, hold on a sec. And a lot of you already have my cell phone number, which is pretty funny. I'm not going to put it in chat. No. But here, hold on a sec. Because I want to hear from you. All right. So, Kayleen, check your mail, okay? Thank you, guys. Sherry says, I live in the bed, as you know, Jill. I know, Sherry. I'm hoping to get the case cracked soon and have surgery. Just need to find the right specialist. Thinking I have endometriosis residual scar tissue because I've already had the hysterectomy in my 20s with a pinned up bladder, cleaned up the endo at that time, but I know the doctor didn't get it all. And my bladder and rectum have prolapsed again, hence the cystocele and rectocele. Also, the main thing is always pudendal nerve entrapment. Anyway, in bed full-time for 15 years. New doctors always just want to treat me for IC, so I get nowhere. You're in the Dallas-Fort Worth area. Sherry, you know, girl, I'm going to say this in the best way possible. You are a beast. You have endured pain for 15 years, and you are still here fighting. And you are not giving up. And I am so proud of you. And I'm so impressed by you. This is, you know, and clearly, you know, the AUA guideline, you're going to have to bring our fact sheet with you to these appointments now. Because seriously, you've had multiple pelvic traumas. You have had multiple long-term muscle issues. You have had bladder prolapses, endos, et cetera, and now you prolapsed again. How anybody could ignore that is shocking to me. You are not bladder-centric. You are pelvic floor-centric, right? I mean, you've had muscle problems. The bladder does not cause your muscles to get so weak you prolapse. Other things cause that. So I admire the hell out of you, girl. You are tough. And guys, we as women in 2022, we better all learn to be tough. Because life is getting pretty scary right now with people telling us what we can do or not do with our bodies. I'm not going to get into politics, but seriously. Ooh, do not even go down that pathway. Sorry. Oh, that's because you're on a delay, Kayleen. You guys, the Facebook feed is on a 30-second delay. That's the software. You know, I think it's. I don't know if any guys are watching right now. For the guys that are watching and listening, listen, guys. I want you to know that your needs are as equally important to women. That many men who develop pelvic pain are, I mean, for women out there, I mean, listen, we're used to being discounted. And we've grown up this way. We understand that society often puts the needs of women secondary to other things. But you would be shocked at how men are treated by other men when they have pelvic pain. So I don't want any guys listening to this to think that we don't hear you. And you know that if you call me, I will always spend extra time with men, because we women, we have support. Men don't. Men don't talk to each other. And men have their own unique challenges that we absolutely have to embrace and endorse. And so, guys, I'm here for you, and I will help you as much as I possibly can help you. But if we can just take a moment and talk about how incredibly important it is that we as women not allow other people to tell us what to do with our bodies. It is our body. If somebody said the only way to treat you is with surgery, despite the fact that there were other treatments, would you do it? Just because you have somebody powerful say, well, let's just take your bladder out. Are you going to do it? Or are you going to research it a little bit more? Listen, we're not subservient. We're not weaker just because we have pain and just because we're women. We're equals. I want you to walk into every single doctor's office with your head held high, looking people straight in the eyes, asking good questions, being prepared to have a good conversation, knowing your stuff. We cannot allow ourselves to be put into a position where we're told this is all in our head anymore. And think about Kayleen here. Kayleen, massive endometriosis. She has suffered seriously for years now. And because she's younger, and God forbid you be a young woman asking for help, do they respect, do some people discount younger women? Absolutely. Absolutely. And if you're a young woman, it's intimidating to walk into a doctor's office with somebody who is looking down at you. Remember, I told you that I had a doctor when I was 33 years old say, you will forever be a burden on your family. That's the way they talked to me. And that was the moment I started fighting back. Like, oh, hell no. How dare you say that to me? I will prove you wrong, you son of a bitch. I have 3 college degrees. I will prove you wrong. And that's when I went home and I started to fight. And that's what we do. That's what every woman and every man with this has to do. You got to fight. Not be rude, not be insulting, not be demeaning. You got to understand your doctors are going through hell right now themselves. But I refuse to accept this anymore. I'm done. I'm over it. I'm over it. I am over people having the audacity to tell IC patients it's all in their head. You do not get to tell me that. I'm living in my body. I can tell you I have pain on the left side when I sit down that is associated with my SI joint. That is not all in my head. Some of you can say, I have blood in my urine. That is not all in my head. How can something in my head cause my bladder to bleed? What the fuck? Excuse me for swearing, but I'm sorry. I am more of a, I'm a women's liber, but I'm an IC liber. Enough already. Stop with the insults. Stop with the demeaning talk. Look at me. Don't look at your freaking computer. Look at the tears in my eyes. I need your help. I'm trying to figure out how I can live with this. You know? And so, like for Shayna, Shayna, I'm not sure if that's the right way to pronounce your thing. So Shayna here is hormone driven. She had her bladder screams every 12 days, and she gets bladder pressure and urgency. She's sure it's hormonal. I am sure it's hormonal for her too. Absolutely, because it happens every 12 days. And it would be really interesting, Shayna, if you started tracking it with the dates when you ovulate and stuff, so you have a little bit more data there. I can promise you, when she goes to most gynecologists and says, this is hormonal, they're going to laugh at her and say, no, it's your bladder. Well, it's a combination of both. You know, we have to make our case. We have to walk in with good evidence. We got to walk in prepared to discuss stuff, right? Sue, in the middle of this IC nightmare, I got a diagnosis of leukemia last week, an appointment with a cancer. Oh, honey, I'm so sorry. Big hug. Big giant hug. I've been there. I have been there. There's nothing worse than you're already feeling like you're fighting and then the big C happens, right? You are not alone. This is not your fault. No shame, no blame. Scary as hell, I'm sure. I need you to take a lot of deep breaths and give yourself a lot of rest, a lot of comfort. You're entitled to eat cinnamon rolls, which is what I did with my thing that happened a couple years ago. For moments when you can't, even 15 minutes a day, you got to start your reading, hon. You got to start your reading. And I would be happy to help you if you don't know where to research that a little bit more. Cancer.org is a great place to start. The National Cancer Institute is a great place to start. The National Library of Medicine, great place to start. If you need a little help before June 3rd and you're just looking for some ideas, give me a phone call and we can do it over the phone, and let's see if we can find some websites that might help you with that. Okay, hon? Susanna says, my dad is listening right now. He's struggling with prostatitis. He just finished his antibiotic and he's not feeling any better. Dad, hey, nice to meet you, Dad. My dad just came in a little while ago. So the thing with prostatitis, so here's the thing, and I'm just going to say this specifically for you. We have to understand that anytime a man has the symptoms of frequency, urgency, and or pressure and or pain, almost every doctor assumes it's prostatitis. And you know, because that's the way they were trained, number one, and in many cases, that's what it is. But there are different types of prostatitis. And so one of the types of prostatitis is non-bacterial prostatitis, chronic pelvic pain. So let's see, how do I want to say this? The antibiotic is reasonable, and definitely let your doctor know that you haven't responded to that antibiotic. Hopefully they've done a culture. Hopefully they've done some good urine testing. Maybe they've been able to press out some prostate fluid and get that culture to see if there really is infection going on there. Understand too that as we get older, and I don't know how old you are, you might become more sensitive to food anyway. Like, again, my 99-year-old dad, he cannot do coffee anymore. It makes him pee all night. He cannot do citrus. He cannot do things like that. He's got the equivalent of a 99-year-old bladder, and it's not particularly acid friendly. So that's concept number two, is sometimes your bladder changes as you get older and becomes a little bit more sensitive. Sometimes what we see, though, in a lot of men is actually a muscle injury. There is this big movement now in the American Urology Association to really stop calling pelvic pain patients chronic prostate patients, because that gets everybody focusing on the organ, which might not actually be the underlying problem. We want them to look in the bladder, and we want them to look at the muscles. Did you fall when this started? When you try to urinate, can you urinate right away, or do you hesitate 5, 10, 15, 20, 30 seconds before you can release urine? Are you struggling with constipation? Those could point to perhaps a traumatic injury, like if you fell on your tailbone, or maybe even if you fell a while ago. Maybe there were just a series of little pelvic injuries that just kind of got turned on now. And of course, we also have to know about benign prostatic hyperplasia, that your prostate is going to grow as you get older anyway. And sometimes it grows into the urethra and it blocks urine. So at some point in time, they might want to use a cystoscope and go up and look at that and maybe do something that might minimize that if that's happening. But we're really now opening our eyes way beyond the prostate. We want to look at the bladder and we want to look at the muscles. And I'm going to tell you right now that the great majority of men that I work with, it comes right down to very tight pelvic floor muscles. They were athletes. They were sitting for long periods of time. They were riding bikes. They were riding motorcycles, injuries, things at all like that. So, you know, track your symptoms. Write them down, and write down any unusual symptoms. Like, do you have a pain that shoots down your leg? Do you have any pain in your knees, in your hips? Do you feel a vibration? I was working with a man who called me about 10 years ago, and he said, Jill, every time I sit down, my penis starts to vibrate. The true story, absolutely true story. My penis vibrates so bad, it almost throws me off the chair. And we know exactly what that is. That's a nerve. He had pudendal neuralgia. He was fine when he stood, but when he sat down, he was sitting on the nerve and the nerve started vibrating. And so, you know, pay attention to any weird, unusual symptoms. Is there a sense of vibration? Is there a tingling? Are there any areas of numbness? Do you have pain at the tip of your penis? Do you have pain on the left side? Do you have pain on the right side? Are you food sensitive? Do certain foods make it better? Do certain foods make it worse? Is it positional? Are you fine? Do you feel better when you stand? Does it feel worse when you sit down? We want to look at the totality of the pelvis, not just the prostate. I hope that helped just a little bit. Linda says, if a woman in Dallas-Fort Worth needs a recommendation for a great uro, I would suggest Dr. Gary Lamack at UT Southwestern. He's excellent. He listens to me and is very thorough. Linda, you should check our database and see if he's in that database. If he's not, we need to get him in our database, right? So we can let other people know. Lori says, what's my opinion on functional medicine? I don't know how to answer that question, to be quite honest. I'd have to do a little bit more reading before I could answer that. I had some immediate thoughts came through, but I'm not prepared to answer that question right now. Sue says, I'm scared. Honey, I know you're scared. I know you're scared. You're not alone. You know, the hard part about getting a cancer diagnosis is it's kind of like the same thing that happens if you have a heart diagnosis. You know, you go through something with your heart and it scares the you know what out of you. And it's like they're not even understanding the emotional toll that this is taking. This is scary. Help me through the fear. Get online, but don't be on Facebook. Go to the nonprofit websites and get into their support groups, honey. Get into their support groups. Just don't do the Facebook groups. Go to the real organization and get it from the experts. They're the ones who are going to help you the most. David said, when Jill found out I was suffering, she had me get in touch with her right away. She took her time, didn't rush me, and wanted to make sure I had a plan before she got off the phone with me. You betcha. You betcha. Happy to do it anytime, long as I have the time. Shana says, I have a urogyno who's helping me with hormone replacement therapy, but every appointment he says, I just don't know what else to do. It's just a worse feeling. And I'm reading articles on the correlation between HRT and IC, and it's just so confusing. Is this why he doesn't understand? Yeah, honey, that's a thing. I mean, that's a thing. This is very difficult because we all have our own unique tolerances. You know, again, for some people, they flare when their estrogen is high. For others, they flare when their progesterone is high. This is a whole unknown field here. And so I think if he's willing to try and you're willing to try, you know, that's what you're going to need to do. Hold on a sec. I just had a brain thing. Hold on. Hold on a sec. Hold on. Let me see. I wonder if this book, this is Facing Pelvic Pain, edited by Dr. Elise Day. And this is by far the most comprehensive book on other conditions which can cause pelvic pain and IC symptoms. And hold on a second. So there's this chapter in here on Which gynecological conditions can lead to pelvic pain? And let's just see if there's a section in here on hormones. No. You know what, Shayna, do me a favor. Email me or call me this week, and I'm going to email Dr. Day for you. And I want to see if she has, because I haven't gone into this in about 5 years, to be quite honest. I mean, I haven't studied hormone influences probably in about 5 years. So, you know what we can do is we can email her, because she's talked to all the experts, and see if there's anything new there, okay? You know what? Wait, hold on. Let me just do it. You guys can help me write the letter. Oh, you know what? I'm on the wrong computer. I can't do it. Shayna, call me or send me an email, icnetwork@mac.com, and maybe you and I together can do this, okay? I'd be happy to try to help. Finding that balance is hard. Susanna says her dad says hi. Hi. Shayna says it sent 530 stars. Thank you. Dad is 79. Oh, you got the bet. Hey, listen, 79 is the new 59. I will tell you, Dad, that my dad is at 99, is going up and down flights of stairs several times a day, and is on the computer all day and reads like a beast. So keep it up. Keep it up. David says, you have benign prostate hyperplasia. You take Proscar. They also have Avodart. I have issues from time to time. I also have IC. Can't give me a reason for the prostatitis. And David, also in this book, David, this has a whole section on what male problems. Hold on. Which male urological problems can lead to pelvic pain? And you guys, this book is free on Kindle Unlimited. At least it was the last time I looked. Facing Pelvic Pain, Dr. Elise Day, DE. David, you got to read this. What prostate problems can lead to pelvic pain? Enlarged prostate, acute prostatitis, chronic pelvic pain syndrome. How does the prostate cause pelvic pain? This is a good chapter. This is probably the best chapter we have up to date for men right now. Susanna says he does have BPH. He's sitting here with me. He had a cysto without. Dude, you had a cystoscopy without anesthesia, which is very hard for men. Right, David? It's very hard for a man to have a cystoscope put up their urethra to look in the bladder without anesthesia. I'm sorry that you went through that. And it doesn't surprise me that you've had pain after the procedure. How long when did you have that done? Was it recent or was it some time ago? Good night, Erica. David says he refuses to have any more cystoscopies with anesthesia. Very important for men. Thank you, Susanna. Sue, thank you for the 200 stars. Sherry, thank you for the 200 stars. So, Susanna, when did he, or Dad, if you don't mind, I can call you Dad too. When did you have the cystoscopy? So he had the cystoscopy 2 months ago. Has the pain gotten better in the last 2 months? Or has it stayed the same? And where is the pain? Is the pain centered, or is it to the left or right of centered? He's drinking cranberry juice. That's a problem, hon. Cranberry juice is going to irritate the hell out of your bladder. Why are you drinking cranberry juice? Are you trying to prevent an infection? I drank a quart of cranberry juice a day for my first year, not having a clue that it was making me worse. No, I had no clue it was making me worse. So where is the pain? Is it centered, or is it to the left or right of center? And is the pain in your abdomen, or is it lower? So it's pain. Okay, got it. What makes the pain worse or better? Does sitting make the pain worse? And does he feel, and okay, and lower back pain. Does it get worse when he sits down, and does it get better when he stands up? That's what we call positional pain. Does it change as you move your body? So with positional pain, it's usually worse when you sit down, and once you stand up, you feel better, although other people might be the opposite. It gets better when he stands or lays down. Isn't that interesting? Okay. Is urination painful? When is the pain the worst? Before he pees, while he pees, or after he's done peeing? When is the pain the worst? Before, during, or after urination? Before, during, or after urination? When is the pain the worst? He has burning when he urinates. Okay. And is that burning in his, where is the burning? Is the burning up in his scrotum? Is it in his urethra, or is it at the tip of his penis? And I'm sorry for asking such personal questions, but we talk about this all the time. This is very common. So no shame here. And this is all new from the cystoscopy, right? In the urethra and okay. And so this is all new since the cystoscopy, or is some of this pain from prior to the cystoscopy? All new since he had the cysto. And again, the pain is about the same. It's been 2 months. The pain has not gotten better, correct? It's about the same. Did they do did they do anything when they did the cystoscopy? Did they provide any treatment at all? Like, did they I mean, did they do anything in addition to just looking? And also, did a urine culture prove that he had infection? Did he have a positive urine culture? Sorry, Dad, I should just be talking to you. Did you have a positive urine culture? So, no, the doctor just looked, the urine came back okay. Okay. Well, as David said, he said he would never have a cystoscopy again without anesthesia. You know, the cystoscope is wide. It's, and it's bigger potentially than the size of your urethra, especially if your muscles were tight, then your urethra would potentially even be narrower. And so anytime you put a cystoscope in, you're running the risk of traumatizing tissue. So concept number one is, was anything injured and or traumatized? Normally, and David, help us with this because you've been through this. For a woman, when we have a cystoscope, I mean, we might be uncomfortable for a couple of days afterwards. Um, um, for a man, because your urethra is so much longer, and because there's, 7 inches or whatever that are actually being stretched. David, if you're still here, when you had this cysto, did the pain last? How long did the pain last for you? So skin can be traumatized, tissue can be traumatized, tissue can be injured. Your prostate might have been pushed on a bit, right? And of course, anytime you put a medical device in there, you're also running the risk of pushing bacteria in there. We call that a nosocomial infection. Um, uh, you've had a urine culture, though, it came back negative. Uh, you could you could have a next generation urine test just out of curiosity, just to see if they missed a bacteria or there's a difficult to diagnose bacterial infection that's going on. That would be reasonable. Um, One of the things I remember, gosh, this was like 20 years ago. I had a mom call me whose young son had pain, and he was like 4 years old, and he couldn't verbalize it. All he could show his mom was grabbing onto his penis and saying, "My pee-pee hurts, my pee-pee hurts." And this little 4-year-old was diagnosed with interstitial cystitis. Well, she ended up buying him George's aloe juice. Now, aloe on a burn can feel good. And so we certainly know that aloe, if you have a sunburn, you can put aloe gel on it and it will feel good. But we also know that aloe in the bladder, provided that it's prepared correctly, has to be anthraquinone-free aloe, has the potential of soothing the skin of the bladder. And in the case of this little boy, aloe stopped his urethral pain. I think probably what happened to him is like that he was probably riding a tricycle or something like that and ended up with an injury. That's my guess back then. But you could try something that's soothing. And so Georgia, there's only one aloe drink that I've ever had a good patient report from, and that's George's aloe, and it's on it's George's aloe vera juice, and you can find it on Amazon. So I mean, look at the ingredients. I don't know if you have sensitivities to aloe or anything at all like that. You know, we're guessing, and obviously I can't give you medical advice. I'm just trying to give you context and give you a little bit more information so you can work with your doctor more effectively. But aloe is certainly something where we have at least one study in the IC world which shows that aloe can be soothing to the bladder, and that's why aloe has been quite popular in the IC world for over 20 years. If there are challenges with aloe, if it's not processed correctly, it can cause stomach distress. And even for people who are sensitive, it can cause stomach distress. Denise says, I use George's aloe. It's very good and totally tasteless. It's on Amazon. Thank you, Denise. Thank you. And Denise, does it help you too? I think that would be interesting because men really end up with a lot of urethral sensitivity. And the fact that you're having burning when you're peeing points to that. So George's aloe drink would be very interesting. And I'm hoping that something like that this will just be very, very short term and it'll be over. Once we soothe that tissue, you're fine and life goes on. Hold on, let me grab one other thing. Speaking of Amazon, I'm getting a delivery right now. All right. So we have talked about PEA. PEA, also known as palmitoyl ethanolamide. So this is from Natural Approach to Nutrition. And PEA, we had a research study in 2019 that showed that it was remarkably sensitive at reducing IC pain. This has been available in Europe for a couple of decades, studied extensively. We have many, many research studies with fibromyalgia, burning mouth syndrome, sciatica, acute pain, chronic pain, extremely well tolerated. And the general consensus among the researchers is that PEA, palmitoyl ethanolamide, is particularly good at calming nerves down. And in fact, there was a discussion string last week on one of the doctor member boards that I'm a member of with a patient who had severe pain. And one of the other doctors said, have you tried PEA? So palmitoyl ethanolamide, we really are focusing on now as being a non-opiate alternative to trying to reduce pain and discomfort and sensitivity, right? Well, Allopath contains the soothing effect of aloe with the nerve calming effect of the PEA. And so Allopath might also be very interesting to try. David says, when the doctor checks my prostate in the office, I have discomfort for days in my prostate. Yeah, man, that tissue gets challenging. And I just think as we get older, you know, we have a lot more wear and tear injuries and a lot more tissue sensitivity as we get older. So Denise says, George's aloe, you know, I should be selling George's aloe in our, why are we not selling George's aloe in the IC Network shop? I'm an idiot. Why haven't I even thought about that? Well, hold on a second. Can I just write a note to myself here? Let me see if I can get it. The challenge is it's heavy, it's a liquid. So the shipping costs are probably a lot cheaper on Amazon than they would be for us. But I'm going to just make a note to myself and see if that's something that we can bring onto the IC network, because that's been such a historically good product. And Denise said it also lowered your AIC. I don't remember what AIC stands for. What does AIC stand for? Off the top of my head. Hold on. Let me look. I don't know what it means. I probably do, but it's not coming to me right now. Oh, a high AIC value means that you have too much sugar in your blood and you may have pre-diabetes or diabetes. Interesting. Oh, that's cool that it's lowered it for you. That's wonderful. Ah, thank you. Thank you. I went sugar-free yesterday. I'm really cutting way down on my carbs right now. PK says, here, hold on. I need to talk to you after this meeting. I have an appointment with Social Security for disability. Need to ask you questions. Can I call you after you're done? Can we do it right now, hun? Because usually at 4 o'clock, I have to connect with other people, like family, because it's Sunday. My phone number is 1-800-928-7496. PK, I'll make you a deal. If you want to call me right now so that I can answer this while I'm doing the live stream, they won't hear your voice, but people watching will hear what I have to say. This would be a great moment. If you want to give me a phone call right now, 1-800-928-74. Oh no, actually, let me give you a different phone line. 707-538-9442. That's my direct line. That goes to that phone right there. 707-538-9442. If you call me right now, I will answer it online so that other people can hear my answer too. Would you be willing to do that? And I'll keep your name out of it. It's okay. I'll keep any personal information out of it. Presidim said, with restricted food, I feel my bladder has started to heal and I find a tremendous change with suitable foods. Awesome. What do you say, PK? Sylvian says, I enjoy your live. So much helpful information that gives us control over our health. Thanks for all you do. Thank you, hun. Thank you. I love what I do. Okay, hun, call me right now, 707-538-9442. And we'll just do this right now online. They won't hear your voice, but they will hear my answer to you. How does that sound? Call me right now. So for a lot of you who call, you don't know I'm on a headset. I can go houses away with this headset. I love this headset. Okay, while we're waiting for PK, any more questions? I double dog dare you to embarrass me. I'm willing to talk about anything. Anything. All right, PK, call. So hopefully tonight, if not tomorrow, just so you know, I will have a whole new blog on our website, and I will start updating the information on our website, and you will be able to download our fact sheet on the new guidelines for IC. As I was reading this today, there are a couple of little mini missing words I got to fix. All right, PK's getting her phone right now. And so hopefully I will have this up. There's going to be a lot of editing on the IC Network website for me to update everything now. It's probably going to take a couple weeks to do. Also, we do have new guidelines from the let's see, the EAU, European Association for Urology. Hi, Donna. Nice to see you, girl. How are you today? I hope you're having a nice Sunday evening. We've been having a pretty fun meeting today. We're just waiting for PK to give me a phone call. And we're going to do the phone call on. How are you? Oh, thank you. Thank you. Always happy to help. Okay, so you were denied disability and you're going to go have an appeal. Tell me exactly what's happening. Is this your first meeting? Okay. It's your first meeting. I did work for Social Security before grad school. I did for a year. Yes. Well, so are you applying for Social Security disability or are you applying for SSI? Okay, and how old are you? Okay, and you've worked at least 10 years, correct? Okay. 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 Yeah. Yeah. So, okay. o- Okay. So have you completed your application and you've already submitted the application to Social Security? Or is this part of your, I mean, did you fill out that really long application and send it in already or not? You you haven't done that yet. So this is really your interview. So you're prepping for your interview with the claims representative, Social Security. And are you doing this by phone or are you going to go down there? Okay. Okay. So that's good. It's good to do it by phone because you have to understand with Social Security that one of the things that the claim rep is doing is they're evaluating what you look like. They evaluate how you talk. They evaluate how you move. I mean, I know I work there, you know, and one of the mistakes that patients make when they're having that interview is they dress up and they don't go to the bathroom. And you know, so this rep is going, well, hey, I've been talking to you for 90 minutes. You haven't gotten up to use the restroom once. So clearly you don't have a bladder issue, right? So the very first thing that I would do with your appointment, I mean, with your interview, aside from number one, telling the truth every moment, is stop and use the restroom whenever you need to, because they need to witness, even by phone, how your life is disrupted by this. And so if you need to go, you need to go. If it hurts, it hurts. If they ask you what your symptoms are, don't minimize it. Don't say I'm fine. Say I'm in pain. I hurt right now. Okay. And so there is a disability ruling that Social Security did several years ago. You can find that on our website. I would encourage you to read that. A diagnosis of interstitial cystitis is not an automatic approval for Social Security disability, but it is certainly not excluded. But they generally look for more than that. They look for the totality of your symptoms. So, yeah, I know, hon. Yeah, it's okay. 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 So this is all good. This is all going to support your application. This is all good. I mean, so what she was just sharing is that she has multiple pain conditions, right? So we've got. So why don't you leave your house? Okay, so it's, and that's real. That's perfectly real and perfectly justified. You should not feel any shame or any blame. This is something that every IC patient goes through. Anybody with any bladder or bowel issues would have exactly that same fear. Okay, so you don't feel bad about that. Um, are you making any treatment progress at all with them treating that? Are you getting better or worse with your bowel? I get it. I get it. I get it. Yeah. Yeah. Right. And guys, for those of you listening, you're not going to hear her. You're only going to hear my side of it. Okay. So, um, so this is all good for you. Understand, number one, that in your interview with Social Security, you need to go over the fact that you have bladder issues going on, you have bowel issues going on, and I won't say the other thing that you're going on because I don't want to embarrass you online, but I've had that too. And we can talk about that privately offline. That's okay. Chronic overlapping pain conditions are in patients who have two or more of these conditions. So if you have IC, IBS, do you have vulvodynia? Do you have any pain on your vulva? Ooh, okay, 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 okay. So, okay, right, right. Did they, but they also must have connected that to Advil use, right? Because Advil also can make your stomach bleed, right? Yeah, it certainly could have. So Sherry here online says, when filing for disability, it's most effective and almost necessary to have a mental as well as physical disability. Most likely, if you're experiencing IC, you'll be depressed or have anxiety. So claim mental as well and seek treatment for it as with the physical disability. And she's right. She's right. It's about the totality of symptoms. Understand that Social Security, you've got state insurance and federal insurance. State disability insurance is designed to help you get back to work. So people get state disability, which is again only available for 1 year if they get a broken leg or if they're in a car accident, or if they have a baby. And the intention of state disability is to get you back to work. And so when you the state normally gets a percentage of your paycheck that goes into that disability program. So it would be called SDI on a paycheck. Federal disability and Social Security disability is for when it doesn't look like you'll be able to work again, when your symptoms are so severe, the doctors do not see you being able to physically work for a period of time, usually several years. So to establish that disability, you have to really tell them everything. You need to tell them all the ways that it's affecting you. I mean, you are the perfect case. If you've got blood, it's not a mental illness, right? And so nobody can say that this is all in your head when you have visible blood in your urine or in your bowel movements, right? And that's a type of point that I think you have to emphasize, is that when they were looking at these various conditions, this is what they found. And yes, of course, I'm upset about it. Of course, I'm not living a normal life right now. Of course, I would love to be able to get out and work, but I can't because I am completely bedbound, or I am completely incontinent, or I am completely this or completely that. They're not your enemy, but they're your credibility checker, you know? Um, and I'm just a little bit unclear. Do you have a work history where you really did work for roughly 10 years so that you were qualified for Social Security disability? Or have you never been able to work? Okay. Okay. But were you paid? Were you paid? Okay, so you have to work it's called 40 quarters or 10 years. You have 4 quarters a year to actually be qualified for Social Security. So the good news is it does sound like you're qualified. They're probably going to ask you questions about that. And then, just answer their questions as honestly as you can. Uh, and be as descriptively bloody as possible. You know what I mean? Like, don't just say, I have to pee a lot. You want to say that you don't sleep through the night. How often do you get up at night to pee or have a bowel movement? How often are you getting up at night? No, really, how many are you able to sleep or not? But how many hours did you sleep last night? Okay. Okay, it's not terrible, but not ideal. That's, you got a little bit of sleep. You didn't get a lot of sleep. That's the type of information they need to know, because it's really hard to work if you don't have mental clarity, and you don't have mental clarity if you're sleep deprived, right? So Well, but see, that's what stress does. This is the most primitive part of your brain that is thinking that your life is in jeopardy, and it's putting you into a stress response. It's putting you into fight or flight. And what happens is it raises your heart rate, it raises your blood pressure, and it tightens your muscles. That's a stress flare. The stress isn't causing the IC or the other issues, but it is exacerbating it. That's a connection. And so it's completely normal to have anxiety when you live with pain like you're living with. It's completely normal to be depressed when you have suffered to the degree that you suffered for so long. And good. And that, again, and that's something that they should know because, as Sherry just said, that's going to only bolster your case so that they understand the many ways that this chronic overlapping pains are disrupting you, right? So you just need to, don't hide anything, be truthful, be honest, and tell them the many ways that your life is disrupted. Okay? And it's just the interview. Now, I'm going to warn you that like 95% of everybody is denied the first time out, and it's just what we would call pro forma. They deny it, but they're just testing your will, to be quite honest. I do not be offended, hurt, or surprised if you get denied. Do not. Right. Well, but you've got to have good medical evidence and information to support your case, and so hopefully you've got at least one doctor who says they believe that you're disabled, and let's go from there. So we have a disability resource on the resource center on the IC Network website. I would encourage you to read through that, and I think you'll be fine. Just put it all together. Don't just focus on your bladder or focus on your bowel or focus on the anxiety. They're all together. And if anybody says, well, do you think this is all caused because you have anxiety? Your answer is going to be no. Anxiety does not cause my bowel to bleed. Anxiety does not cause my bladder to bleed. There is a fundamental there is fundamental disease happening in my body that certainly has made me anxious, but my doctors have been unable to give me treatment that has made me better. Believe me, I want to be out. I want to go out and enjoy life. I want to go out and do this, and I want to go out and do that. But right now I can't do that. I'm tied to a bathroom right now, right? Well, you are right now. You are married to the toilet right now, and so we've got to try to get the underlying anatomy calmed down, and a big part of this is going to be you you working on your central nervous system because that's a connection. The reason why the bladder gets sensitive and the bowel gets sensitive, and you might end up with a little bit of fibromyalgia or chronic fatigue along with the anxiety. The centerpiece here is the fact that your nervous system is kind of stuck in fight or flight, and that's what happens when you've been in pain. If you've been in pain for 14 days, your brain automatically goes and tends to stay in fight or flight. And then it's the fight or flight that makes everything that much worse. And so while you're doing the therapies that you need to do for your bladder and your therapies that you need to do for your bowel, you also need to be working with that therapist that you already have that's going to help you with the depression and the anxiety and the other stuff that's going on. But don't let anybody tell you that you caused any of this. You didn't cause any of this. You're hurt. You were hurt. So anyway, well, listen, hon, I hope that helped a little bit. I think you'll be fine. Just don't focus on one thing. You got to focus on the totality of it and give them the bloodiest details you can give them. Tell them how it disrupts your life. Tell them the things that you cannot do. I can't go shopping. I can't do this. I can't, I mean, just be brutally honest about why you can't get out of the house so easily. Okay. Okay, honey. Keep in touch, and I wish you well. And if you want to give me a phone call, I will be around Tuesday. Um, yeah, I'll be around a bit on Tuesday too. Okay. Yeah, that's a good idea. I think it would be good for you to have all your information in front of you before you do this. Just understand that they have to establish that you're eligible. And if you wait too long, you might not be eligible. So there's a part of me that's saying you should have that interview as quickly as you can so we don't miss any deadlines. Like if you haven't worked in 10 years, and I forget the exact number, then you have to have paid into the program in the previous 10 years in some way. So there's a part of me that says I would want to take that interview as soon as possible just to deal with the eligibility stuff. And maybe you could say, when you start, I only have half of the information and I will have more. Would you like to reschedule? But in the meantime, do we have any questions about my eligibility? Does that make sense? Yeah. 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 And ask them for tips. Tell them, what can I do to really help you understand my disability? And say, if you were in my position, what do you think is the single most important thing or the five most important things that I can give to Social Security to help prove my case? And just try to, because they're human beings too. If you try to appeal to their sensitivity, they might be able to give you new things that I don't know about because it's been many years since I worked there. But anyway, listen, hon, I got to run. Nice talking with you. I wish you well, and please keep in touch. Okay. Afternoons. Afternoons. Yeah. Okay. Big. Oh, big giant hug to you too. Okay. Bye bye now. All right, you guys. That's a really, those were good questions. Really good questions about Social Security disability. I was working with one lady. She was down in Southern California, and she waited and waited and waited and waited. Her IC was really bad, but she just really wasn't. She knew she needed to apply, but she waited, and she ended up waiting too long. And she surpassed the deadline and was not eligible for her disability after that. So it is an insurance program. You have to pay into the program to be entitled to the program, and it's not indefinite. If you haven't paid into it within a certain period of time, you might lose your eligibility for disability. Not so for retirement benefits. Retirement benefits are a different thing. Prasidum says, I'm having constipation. Do I need physical therapy to work on the muscles since they're tight? Physical therapy certainly wouldn't hurt, but you also got to get your fiber up and try to figure out if the reason you're constipated is because you're not eating enough fiber, maybe not drinking enough water, et cetera, et cetera. Got to focus on both, my friend. Focus on both. One, I hope you like green peas. Green peas are very high in fiber. They're wonderful. And so if you could have one big serving of green peas every day or every other day, that would go a long way in helping. Or baked beans. I whip out the baked beans all the time for me and for my parents, because in our home with a 99-year-old and a 93-year-old, it's all about peeing and pooping. That is the totality. David, I don't know what you mean by talk to everyone next time. I would try. Sherry says, while listening to you on the phone, it reminded me When I claimed disability, it was my sleep deprivation that was the most important symptom I could use. And then others with IC, chronic pain, frequency, but the sleep deprivation, physical and mental, can cause so many serious problems. So you must mention that. And of course, if you actually have that symptom, Amber said, I just started using Humira for other issues. Is there a possibility it can help? And somebody asked about Humira. There was a research study with IC and Humira. Let me see if I can find it. Hold on. So in 2014, hold on a sec. Well, that's old information. Let's see here. So small research study, 43 patients, 21 received Humira, 22 received placebo. Of the patients who received Humira, there was a statistically significant improvement in their IC symptoms at 12 weeks compared to baseline. At 12 weeks, 53% of patients, 11 out of 21 patients, had a 50% or greater improvement in their global response assessment. There was not a statistically significant improvement in any outcome measure in patients receiving, there were no significant adverse events. So the conclusion, patients with moderate to severe interstitial cystitis resulted in some improvement. But however, there was a significant placebo effect as well. That's all I'm seeing. That's all I'm seeing on it, hun. Well, it could be. I mean, power to you, hun. If you're feeling better on it, that's great. You know, just look at the side effects. Take a little time to read the materials that came with it so that you are aware of the side effects that could happen, and power to you. Go for it. I have no experience with it, so when I say go for it, don't assume I'm saying it's good, because I have no personal experience with it. I'm just saying that if you're feeling better on it and your doctor told you to try it, that's a doctor saying, why not give it a shot? And you're starting physical therapy in August. Yeah, there's a long waiting list right now for physical therapy, definitely. So, all right, my friends. Well, I mean, listen, we've been going for 3 hours here so far. So I'm going to do a last call for questions. I found, Proceed said, I found the glucosamine chondroitin supplements. Thank you for your support. Oh, you're very welcome. Which one did you pick? Did you pick a bladder builder or bladder rest or Cystomend or Cystoprotect? Which one did you pick? All right, Facebook, last call for questions. I know we're just down to a handful of people here. So if you don't have any, that's fine. I'm going to hope that you have a great week, and we will see you again. We will see Facebook, see you guys either on Thursday night or Friday night of this week. Every day is an adventure. Let us hope we all have a very good week with no more calamities anywhere. I just want a normal week where everybody's healthy, et cetera, right? I'll see you later, John. All right, guys. I'm going to sign off. Be well. Have a good one. All right. Facebook is done. All right, YouTube. I will see you guys later. Have a good one. Oops, wrong mouse. I need the mouse for this computer.